We want to welcome everybody to Expert Venous Management, and this year it is virtual and interactive. So those of you who have joined, I want you to, it's virtual, but the second word is interactive. This meeting is conceived, and when we do it in person, there's a lot of discussion, interruption, questioning, whatever. This is for a way to have dialogue between all the different venous experts that are either on the panel presenting or those of you in the audience. And I want you to keep that in mind. Part of this experience and part of what makes the meeting what it is attendee participation. So you have two ways that you can participate. One, at the bottom of the screen, you can raise your hand if you'd like to. You can also submit questions in Q&A. And so we can have either someone will read the questions that you might submit, or if you do have something you want to say, just raise your hand and we will unmute you and have you go ahead. The way the meeting is formatted is that we're going to have short case presentations, no lectures about, testing for vein disease or about valves or any pathophysiology. It's all case-based. Short cases. There will be questions during the case for the audience to answer, so we get some idea about what you're all thinking. And then during each session, we have what we call the front row. We have three other faculty that will be on screen, and you'll see who they are. And they too can ask questions, and we can interact. And you all can ask the questions as well. So we're going to start out. The first session is going to be focused on superficial veins. Peter Pappas is going to be our first presenter. Peter, if you can bring that up. Okay. And our first row is Kabnick, Marlon Schul, and Sarah Onida from the UK. So Sarah, it's the afternoon for you. So let's start and see where we go with this.
All right, so for those of you on the East Coast, good morning. So Steve asked me to present some complications after superficial vein management, and so hopefully these two will be educational. So the first patient was seen in September 25th of last year. She's 91 years old. She's a white female with a history of a hernia repair, anemia, cellulitis, arthritis, atrial fibrillation, which she is not in when I saw her at that time, heart murmur, basal cell, melanoma, thyroid disease, all the things you would expect to see in a 91-year-old. She presented complaining of pain, fatigue, restless legs of both legs, swelling, but her primary complaint was that she had two ulcers of the left leg, one in the medial aspect and one posteriorly, that has not been healing. So these symptoms had been occurring since February of 2019. I saw her in September. She'd been going to a wound care setting. Her pain was typical of a non-healing ulcer. And like I said, she was being treated at a local wound care center with periodic sharp debridement and enzymatic debridement. And she was very, very fully compliant with her compression therapy. Also, just to let you know, she is living at home. She has a very supportive family, and she is mentally fully functional, and also physically a little on the frail side, but overall a very functional person. So the past medical history as stated above. Past surgical history, she did have an aortic valve replacement, and she has had some orthopedic procedures in the past. Medications, when I saw her, she was on aspirin. She's on levothyroxine for her thyroid disease and mirabetrol for some bladder issues. Ibuprofen for the pain, and she's also a beta blocker that she was placed on after she was in atrial fibrillation. On the social side, she's never smoked. She's not an alcohol drinker. She is a retired teacher. So on physical exam, she was very, very thin. Her BMI was 20. She's weight is 104, slightly on the cachectic side. She also has a kyphosis. She does have a murmur of 2/6 that you would expect with her aortic valve repair. She was not in atrial fibrillation at the time. And then on her extremities, two medial and one lateral ulcers. So this over here is the left leg. So this is one of her ulcers. She also has a little scab over the ulcer here. And she also has an ulcer posteriorly. So her preoperative duplex scan is as follows. She had no axial reflux in the grade system. Her primary disease was all in the small saphenous system posteriorly. And she did not have a visible junction, but it did go from her popliteal fossa all the way down to the distal calf. And on the right side, there was some evidence of some prior post-thrombotic disease. I'm sorry, there was bilateral. She had some evidence of some prior disease, but the vein was large. You can see here on the left, it goes from 5.4 to 5.9 millimeters, and on the left, it's slight on the small side at around 3. So at this point, I'd like to ask the audience, what would you do with this patient? And I just threw up some potential treatment options. Keep in mind, she had been treated at a wound care center with debridement and compression therapy and collagenase therapy for over 6 months. And the family was very frustrated, as was the patient, because it limited her mobility and she was in pain. So I put up chronic therapy with continue the Una boots with the compression, bilateral endothermal ablations alone, followed by compression, bilateral varithenas alone, followed by compression or some form of foam sclerotherapy, or bilateral thermal ablations followed by some form of foam sclerotherapy. So what do the panelists in the audience think we should do for this, this 90-year-old lady?
Yeah, so let's start with Lowell. What do you think here?
Well, I would really want to know some more information. Peter, was there a ultrasound extended up centrally to see if there was an iliac obstruction?
So that's a really good question, and the answer is no, we didn't do it. If you want, we can go into why right now.
It's okay.
Yeah, but we did have the discussion with the patient and her family, and I recommended against it at this point.
Fair enough.
Yeah, after you had the ultrasound from the groin down, you recommended, yeah.
How long was the ulcer there that was not healing?
6 months.
Yeah.
Did it look like it should be biopsied?
It did not. There were no round edges. There was a moderate granulation tissue in the base, nothing that would make it look like it was a basal cell or a squamous cell carcinoma.
So looking at your options, I think any of these options are good. Endothermal ablation, sclerotherapy, and compression. Varithena is the same. I don't have any problem with any of these. It really depends on the rapport that I would have with the patient and my judgment as to whether I do a thermal ablation or a non-thermal ablation, depending upon whether to have, how she would react to tumescent, et cetera. So I think these are all really good choices, except for compression therapy alone.
She already tried that, obviously, right? So that was a failure. So now she needs something else.
All right, Marlon, what do you think?
Yeah, I mean, if the deep system is fine and these ulcers are felt to be vein related, I would parallel Lowell's idea that we could use anything for the small saphenous. However, I would say based on her pattern, there's got to be other things left behind. So I don't think with ulcers you can treat those without foam ultimately. You may get better with compression and any axial treatment for the small saphenous vein. I think taking the patient's considerations and what their preferences are, and as Peter noted, the family's preferences are important. Sharing with them what the risks and complications may be for either one, and bottom line is that all of them could have an indication. But I don't think you could do the small saphenous treatment alone without adding foam. I think if you're going to get this ulcer closed, you still have to treat those branches and try to get them completely healed.
Yeah, Sarah, what do you think you would do, Sarah? And if it's not one of these choices, tell us what you might do.
So the first thing would be just assess if she's got any varicosities that are obvious around the area, or whether it's just C4 plus disease. So Dr. Pappas, did she have any prominent varicosities locally?
She did not.
So certainly the SSV needs to be addressed, and I would agree with the other panelists that it could be done via endothermal means or with Varithena. I think the only thing with a lady of that age who's quite cachectic and will have thin skin is just to make sure that she doesn't have a thermal injury if we're going for an endothermal ablative technique. But with adequate tumescence, obviously that can be sort of taken account for. But certainly one would have to investigate also the subdermal plexus as such and under the ulcer, and as to whether any foam is required there. So I would treat the trunk and then, yeah, for the subdermal plexus, perhaps some foam.
Yeah, I mean, I'll just weigh in on this. I mean, you all know I'm a pretty big fan of non-thermal below the knee. And I think of these choices, the Varithena, because she is cachectic and the vein is close to the surface of the skin. Yes, you could do tumescence, but elderly woman with pretty old skin, I would do foam the small as well as foaming, as Sarah, you say, all the peri-ulcer subdermal plexuses. Marlon was saying the same exact thing. Why not do everything with one technique, and then you don't need to worry about nerve injury, but also skin injury in this very cachectic woman. So Peter, move on.
So as the group suggested, I chose to try the bilateral Varithena for all the reasons that were just stated here. So what happened was she had a very good response to the Varithena. And the first thing that happened was the lateral wound, which was the ulcer back here, was the one that healed almost immediately. And then we still had this, I don't know if you can really project well, but this is essentially the wound here. And she's got some overlying like scab right here, but this was started to heal. So we did this in September, and then by November, after the Varithena with the compression, it was almost, like I said, one ulcer had closed and the other one was on its way. Then,
Peter, we should just point out, as Chris Pitman pointed out to us, most of us use this off-label, Varithena for the small saphenous, but for anyone who's listening, that is not an on-label use, not an IFU, but a lot of people do use it for small saphenous, and I've used it many times for small saphenous, as you did, Peter, with good results.
So this was 2 months after the initial treatment. Then a month later, she presented with recurrence of her pain, and the ulcer medially was not healing. At this point, it had stalled. So we repeated her ultrasound, and unfortunately, this is what happened. The reflux in both of the small saphenous veins that was treated returned, and she's back to kind of where she started at now, except the lateral ulcer has remained closed. Her medial ulcer is not closed, and she's still having a significant amount of pain. So now what?
Now what? Sarah, what do we do now? You wanted to do foam like I wanted to do foam.
Well, obviously the SSV, as Dr. Pappas has said, have reopened again, so we would consider having to re-intervene in this lady. You could try giving her some more Varithena or some more foam. That's failed once already. So you could, I mean, you also have to assess as to whether there were any reasons why the treatment failed in the first place, if both recurred, if there were any issues during the procedure, any concerns at all. And yeah, I would start thinking about a different modality. So whether one would consider perhaps going for endothermal ablation at this stage to address the refluxing trunk.
Yeah.
Or any other reasons why she might have failed treatment in the first place.
Anyone have any different thoughts aside from using thermal at this point?
I would be interested to see what kind of if it's wide open, Peter. She'd had prior thrombotic events in the small saphenous veins. Does she still have evidence of some scar after the Varithena?
No.
I mean, I would probably treat this with glue. Treat the small saphenous with glue.
I have a question, Peter.
Yeah.
If I may. When things like this fail, and I don't look at the operator as the problem, I look at the hemodynamics. And there's something that just doesn't did here. So I'm trying to ask whether you did any further studies to see if she had that obstruction or right heart failure, something that doesn't make sense here.
So when it comes to Varithena, I do think the technique matters because I think after it was originally approved, people were not following the IFUs. I was guilty of that myself. You know, I would do sometimes just a percutaneous inject, access and then just inject. But for this patient, she was accessed with a micropuncture sheath bilaterally. Her legs were elevated, exsanguinated, and everything was followed as per the IFU on this one.
And the 2 week of compression?
Correct. I do. Well, that's a good question. So the length of compression, because what we did was because she had an ulcer, she was put back in an Unna boot again. So I don't believe the compression was the issue here, but I do think it's appropriate to ask about the technique because I don't believe everyone in the United States is following the original IFU with Varithena.
Yeah, but here, Peter, you said you did it. And just an aside, let me just say, there's a lot of comments by the other faculty. You all, the other faculty, you can unmute yourself and insert yourself into the conversation. You just don't have to type in your questions or answers. So feel free to do that. I believe you can do it.
Can I ask 2 questions from Europe, if possible?
But how about one from Europe?
Okay, so regarding the primary procedure, did you use the long catheter or this was just a single injection into the vein? Regarding
it was a 7 centimeter micro catheter sheath.
Okay.
All right. So Peter,
my questions, Kathy, is to echo what Lowell said, and I typed that in the chat, is I've found in these elderly people when they fail, and those veins were not that large, so you would be surprised that they failed. Was there any pulsatility in the deep veins on her duplex that would hint that she's got right heart failure?
So there was not.
Okay.
So believe me, I looked at all that too.
And other people have also mentioned at this point that you could look at the deep system in the pelvis for obstructive lesions. But I haven't found that necessarily correlates with failure. I have seen that with the right heart failure.
So Kathy, can I ask you a question?
Yeah.
Yeah, so you've done a lot of Varithena on these axial veins.
Yep.
Is there any data as to the percentage of failures on the first time with Varithena? What percentage of the time does it fail? Because I've seen it at least 5% of the time as a primary failure.
Yeah. So if you look at, the only data we have is from the original trials, that I know of. And the initial failure is higher than with a lot of the modalities that we're used to. I think it's very rare now to find, unless they have right heart failure, when I do a radiofrequency or laser ablation, when they come back, it's closed. Failures are later with those, but with Varithena, you can have, and in my personal practice, an initial failure.
Right.
When it's a vein that's this size, it's a bit surprising because usually the failures that I see are in bigger veins. So it is a little bit head scratching, especially if you did it correctly. So that's why, I think we're all puzzling about what else to look for, but I agree with you. When they come back, it's not a slam dunk like in some situations. Like with thermal.
This is Gil. Oh, hey, and in the Vanish trials, the failure rate was it was in the 40s. I saw Alan put 20 to 30% range, but it was in the 40%. That was the rationale for having patients come back
For a second.
time.
Right, that's right.
Yeah.
The 40% I think was a little further out, not like first
Really,
week.
it didn't cross that. Yeah, and when we were assigning CPT codes to it and trying to get a value for it, it didn't cross the 50% threshold. I remember it was close though, because if it crossed the 50% threshold, then there was an argument to potentially cover the second treatment for reimbursement.
Mm-hmm.
Wait, can I, Peter, a couple of questions that people have. Did you ever image her prior? Was she closed for a while and then reopened, or you didn't know if she ever did close?
Yeah, so our treatment protocol is that every patient comes back for either a 3-day or 7-day scan. Okay. And then at their 1 month and 6 month and then 12-month follow-ups, they get rescanned again. So she was scanned after the initial treatment and she was closed. And she was healing. And then the reason why we rescanned her at this point was because she was stuck, right? She had no further evidence of healing. And she was also at about, I think at that point, between her 1 month and her 6 month scan. So we don't normally routinely scan between that time period unless there's an indication. Her indication was her ulcer wasn't healing and her pain recurred.
All right, so we have a question from one of the attendees. So can that person be unmuted? And if so, ask your question. Mike, are we able to make that happen?
Trying to. I'm here. I'm here. Can you hear me?
Yes.
Is there any point, Steve, in knowing what is happening on the pelvis? If it's a 90-year-old lady and we're just gonna concentrate ourselves in the superficial system, are we going to do anything on the deep system if we find something?
All right, let's see what Peter did. This is Jorge Uowa.
Yeah, and by the way, everybody, this is not the complication I want to discuss. There's a whopper coming.
All right, let's move along then, Peter, because we want to keep going.
All right, so then what I decided to do was then to treat her with bilateral laser ablations followed by ultrasound guided foam sclerotherapy. And then what happened was this. So she was treated on February 5th with the laser of the left, which was her symptomatic side. A week later, we did a USG again of that symptomatic side. And then she presented a month later with new onset. She had a spontaneous hematoma of her calf. And when we did the ultrasound, we saw this collection underneath her calf muscle. You can see here what the measurements are. And what she had was a pseudoaneurysm on the right calf, not the left, the right calf.
A pseudoaneurysm.
Yep. So she had a neck. There was a definite neck connecting the popliteal artery, to the pseudoaneurysm right here, and you can see the flow here, and you can see how big it is here also. So this happened after her her bilateral laser ablations on the right leg.
Okay.
Where did you puncture for the low, or somewhere here?
No, it was a standard puncture right below the soleus, gastroc soleus muscle complex.
All right, so everybody is stumped here.
So the only thing that I can think of is that sometimes, during the case, because we use a bare fiber that goes through the sheath, and I usually tape the fiber down with a steri-strip so that it doesn't move. And occasionally, sometimes the steri-strip doesn't hold and the fiber moves, but I'm usually cognizant and aware of that. The only thing I can think of is that fiber was not where I thought it was, and that it may have been a little bit deeper into the system. But even if that had happened, why a month later?
So Peter, Julianne Stoughton's asking, and let me ask the panel too, you think it's pseudoaneurysm? It's not AV fistula or anything like that?
No, it's a pseudoaneurysm.
It's not connected really.
Could it possibly be the tumescent needle? And also, was she anticoagulated? That's my other question.
Only on aspirin.
Okay. And doing tumescent, you think that's possible that a small arterial injury occurred then?
No, I don't think so.
Well, Peter, Kathy brings up a good point. This is a very thin woman.
Yes.
And, I'm sure the distance between the small saphenous and some arterial thing is relatively close. And it may be an unnoticed stick with the tumescent, because they got to be really, really close.
The other thing, Steve, is, she does live by herself. And she did tell me that she had bumped her leg while she was at home. So this may be true and unrelated. This may not be related to the procedure at all, but I tend to blame myself because this happened in the post-op period. So I'd never seen a pseudoaneurysm beforehand. And this actually had some consequences for her, because she ended up being admitted to the hospital during the COVID outbreak. She ended up getting a percutaneous thrombin injection. And while she was in the hospital, she went into AFib, at which point she had to be cardioverted out of it. And when I saw her back in the office, she was not in AFib, but during her hospitalization, she was. And while she was in the hospital, they didn't do any wound care on her. So she remained at bed rest and leg elevated. And the family was very upset about this, because they knew that if their mom was immobilized, that would lead to other unintended consequences for her. So this pseudoaneurysm and the week to 10 days that she was in the hospital for this, with the ensuing atrial fibrillation and immobilization, actually caused her a fair bit of comorbidity. The good news is, you know, obviously I'm still seeing her in the office, and the ulcer immediately is getting smaller, despite all of this.
All right.
Steve, I have one question, if I may.
Go ahead, and then we're going to
Thank
move
you.
along here. So go ahead.
We've seen AV fistulas, as Julie has reported, and I actually reported that. Has anybody seen a pseudoaneurysm post any ablation procedure? Panel, anybody?
Anybody in the, any attendee, anybody. You can put in your Q&A or chat or whatever.
No, but I have caused a pseudoaneurysm doing a deep venous procedure where I was accessing the femoral vein in the mid-thigh that was successfully treated, and the patient came back with a large hematoma in her thigh and had a pseudoaneurysm from the femoral artery. But that's
That I can understand, Kathleen, but
Yeah.
I'm looking down here anatomically and trying to understand it.
Yeah, I go with what Kathy said. I go with some unnoticed, you know, there could have been a small arterial branch. Other people are saying the same thing with the tumescence in a elderly woman with thin arteries and veins, and just may not have been noticed. And then things just got worse over time. I don't think it's the laser itself. I think it's the tumescent needle, personally.
I would agree with Steve, and the reason why is I think if it was the laser fiber, it'd be a more devastating and obvious injury early than a needle stick. I mean, the tumescent needle is pretty small, but in a lady of this age, you could cause a pseudoaneurysm that just gradually becomes symptomatic with the tumescent needle.
Yeah. All right, Peter, is this your last slide for this case?
It is. I have another case if you want, Steve, where we can.
No, well, we're going to move on.
Okay.
But thank you very much, Peter. You kicked off the virtual interactive, very interactive for sure.
You're welcome.
All right. So, Kathy, you get ready to share your screen, but not just yet.
Venclose introduces the new Venclose RF ablation system, the next generation of radiofrequency technology for minimally invasive treatment of chronic venous insufficiency. Now, a single Venclose catheter is all that's needed to treat both long 10 centimeter and shorter 2.5 centimeter vein sections in one or multiple veins. The catheter's shaft markings are clearly indexed, allowing you to precisely position the heating coil for both long and short segments. And its mild curve and smaller 6 French profile enhance navigation through both large and small vessels. Along with local anesthetic and external compression, each 20-second heating cycle is monitored and controlled to ensure consistent 120 centigrade heat delivery to shrink and close the vein. Since the Venclose system is designed for efficiency, it can also reduce your procedure time and cost. Utilizing the 10 centimeter heating coil, treating a typical 40 centimeter GSV is over 30% faster compared to your current RF catheter. The 2.5 centimeter heating coil not only optimizes more precise ablation of the last short GSV section near the sheath, but also offers the versatility to treat branch veins like the anterior accessory saphenous vein during the same treatment session. Refluxing tributary veins can be treated using the same catheter, eliminating the need to open a second catheter. Now, with the time and cost efficiencies of Venclose's next generation technology, only one RF catheter is needed to treat both long and short vein sections in multiple veins.
Okay. Thank you very much. That's our First, industry has obviously, everybody should understand this, has supported this event completely, which is great. That's why you all can attend this event without any fee. So we want to thank industry, and you'll be hearing from them throughout the entire meeting here and there. So thank you. Next, we have Kathy Gibson is going to talk to us a little bit about multiple tools with superficial reflux.
Okay, everyone see my my slides?
Yes.
So I've got 2 cases set up, but I bet you we're only going to get to the first one.
Whatever.
So these are my disclosures. And okay, the first case. So this is kind of a complicated guy. This guy is 52 years old, and when he was 35, he had an aortic rupture while he was in Central Washington at playing a basketball game, and was heroically saved by actually a small town general surgeon who repaired his aorta, but in the process ligated his IVC when it was injured. And he developed caval and bilateral iliac vein thromboses and post-thrombotic syndrome with venous claudication and non-healing ulcers. And a number of years after that, his IVC was successfully recanalized by an interventional radiologist, and he had iliocaval stents. His venous claudication resolved, but he still had post-thrombotic syndrome and had one chronic ulcer that had been present for 5 years despite wound care. And I'll show you a photo of his ulcers in a minute. So scans, we looked in his deep veins, the stents were still patent. He had reflux in his left common femoral and femoral vein, and on the side where he has the ulcers, no reflux in the popliteal or tibial veins. In fact, his other leg without ulceration had worse deep venous reflux. So this was his superficial vein map. You can see that his veins are very large. Great saphenous vein has sections kind of aneurysmal, 16.4 millimeters and 15.9, not quite aneurysmal, but large. He's got an interaccessory saphenous that's refluxing and his small saphenous. He has multiple large perforator veins. Those are the dots, 6.3 millimeters. And then around the ulcer, which is lateral, he has one perforator that's 5.7 and one that's 6.7. And this is what his leg looks like before treatment. So I think we're ready for our first question, Steve.
Go ahead, ask it, put it, you have it? Yeah.
So then I sent it in, and they were supposed to put it up.
Michael put it up now. So this is a question for all the attendees. You can answer by using your mouse to click on here.
So what is your next management step? Do you do more investigation of the deep veins with venography and IVUS to look for stenoses in his stents? Do you increase compression and perhaps use a biologic, an apligraph, or some other skin substitute for his wound? Do you do truncal ablation alone? Truncal ablation plus treat all of his perforator veins? Or truncal ablation plus treat perforators adjacent to the ulcer? And do remember that he's got Ehlers-Danlos syndrome.
Right.
And how does that play in?
Okay, we'll get the answer in a moment, don't worry. Not the answer, what everyone thought.
Right, and I'm not sure there is a right answer for this guy. You know, I think that there's lots of different things you could do.
Mike, how are we doing? Go ahead, Kath, talk about it.
Okay, so I think that, you know, he had seen several other people before he came to see me.
Kathy, this is Peter. Yeah. Can I ask you a question before you go there?
Sure.
Because you went right to an invasive imaging procedure. You didn't give an option of either a transabdominal pelvic ultrasound or some kind of cross-sectional imaging to assess the patency of his deep system.
He did have the transabdominal one. That was the slide before that that looked patent on our transabdominal ultrasound.
So that was a recent one?
Yes, that was, nope, that was the recent one. That was one we just did. And things looked okay on that. I didn't put cross-sectional imaging on here because I thought we could only do 5 choices, but that would be another option.
So, but clinically, based upon your transabdominal ultrasound, his IVC and iliac stents are patent, correct?
Correct, correct.
Okay, thank you.
Yep. So that would be the question is, do we believe that? I mean, actually, I was pretty surprised that it looked so good. And also, you know, something to talk about is the bravery of the interventional radiologist reopening a ligated IVC in someone with Ehlers-Danlos. So, you know, I guess he had scars in the area, but.
It must have been Kush Desai who did that.
Maybe.
No, I don't have a Washington license.
Oh, okay.
Yeah, I think it was done at the UW actually. I'm not absolutely positive.
It was Meisner.
No, it was not Meisner. It was an interventional radiologist. I actually don't remember because that had been done a number of years before, but I thought that you know might work out okay, but and did and was fine, and probably because he had a lot of scarring in his retroperitoneum. But I know I would be nervous doing that in someone with Ehlers-Danlos that had a ruptured aorta.
So Marlon, what do you think about these answers here? What might you consider doing?
I think you ablate the axial vessels with whatever technology that you would like. They're pretty good size. I would probably choose thermal for these, and then likely foam for the rest of the varices.
So a question that I have is, one reason I was like the third person he'd seen. Other people had not treated him because of fear of thermal ablation in someone with Ehlers-Danlos syndrome. Thermal. I don't know whether that's a valid concern or not, someone with fragile tissues. I don't know if anybody else has treated a type 4 Ehlers-Danlos with thermal before or have any commentary about that.
Well, I'm trying to think what's their concern is what? That you might
I don't know, hemorrhage.
You might destroy the vein that you want to destroy?
Don't know, or I actually don't know. But
we have a pretty big population with Ehlers-Danlos with Peter Byers here, and I don't manage them any differently than I would any other patient as far as their varicosities go. There are some problems with platelet interactions with their collagen, so they bruise a bit more. But other than that, I don't treat them any differently.
Yeah, I think it probably wasn't a valid concern. That's but I didn't know. He's the first one I've had that's been treated this way.
So let me ask Sarah, just yes or no, Sarah, thermal or non-thermal for the axial here? Sarah, unmute.
Yeah, sorry, no, I was just trying to unmute myself. I think in light of the size of the veins, probably thermal.
All right, Lowell?
Thermal.
Okay, me too. Go ahead, Kathy, tell us what happened next.
All right, so I think I had the second one is, let's go here. Okay, so I did not do what you guys said. I used glue. So I did a truncal ablation and I did these segments in this direction. And then I did a second puncture to avoid, he was like very, very woody below the knee. And also this direction here. And then perforator ablation, which I'm not going to tell you what I did yet. And then foam sclerotherapy here and there. So question 2. If you're treating the perforator veins, which most people said they would, can you put the question 2 up? So putting aside what you would do with the truncal ablation, how would you treat his perforator veins?
And you're saying the choice would be, given the fact that you had used glue for the truncal vein.
Yes.
Okay, so we have to put that in. You've used the glue, and now you're saying, I got these perforators at the same setting. What should I do for the perforators?
Correct.
Okay, so that's how we all should answer that, under those circumstances.
Kathy, these perforators are still open after the glue treatment?
I treated them on the same day. I did what the audience said. I did not treat all of them. You could probably see on the other slide, there were like 7 that were over 3.5. I just treated the ones that were adjacent to the ulcer. So
Kathleen, what about injecting the glue in the area of ulcer, especially because of risk of infection? Because there are some fears regarding use of cyanoacrylate in the patient with potential risk of infection, and in reality, you inject this just nearby the
yes.
ulcer. So,
right.
Comments regarding this?
That's controversial. I agree. The Venous Seal Spectrum trial that's going to be launching was supposed to be launched already. We've had a few patients in, and then it was paused by Corona, is looking specifically at one-arm cyanoacrylate in patients with ulcers. In our practice, we use it, and we have not so far had a problem, but we do not use it in patients that have an active infection that's needing antibiotics. So we do it once the ulcer is fairly clean. But I do think that it is a controversial, and we don't know for sure. But in our practice, we use it. Okay, can we see the answers yet?
Let's see the answers.
Okay, so most said foam sclerotherapy. And my kind of feeling about treating ulcers is I tend to use whatever technology I used on the trunk. If they're smaller, I might use foam, but you know, if I'm using cyanoacrylate, that's what I use. It is off-label to use cyanoacrylate in perforator veins, and we do not charge for it specifically when we're doing it because it's off-label. But we've done about 60 perforator veins, I believe now, with glue. And I'm gonna show you.
Yeah, so Kathy, go ahead, keep go there, but what I want to ask the panel here is, is anyone surprised that people who answered the question, the great majority said for the perforator to use foam sclerotherapy?
Yes, Steve, I'm totally perplexed by that choice. Because how do you control where the foam goes in a perforator? Even if you compress, you're going to get some in the deep system. I don't understand. I'd like somebody who does a lot of these perforators with foam to answer that particular question, because I would never choose that as an option for a perforator.
It's not only the deep system. What is the occlusion rates in the literature of perforators with foam versus laser? And we'll get the data soon for, what do you call it? For cyanoacrylate.
Somebody unmute Chris Pitman because he wants to answer.
Yes. Chris, unmute yourself and talk.
I'm happy to answer. Dr. Pitman's an old-time interventionalist who's done countless lower extremity venograms right at the cusp before we even used ultrasound to diagnose clot. There's a number of factors. When you inject foam into, first of all, the flow in the superficial venous system is a fraction of that in the deep venous system. It is hard to get superficial venous blood into the deep system without trying hard. In order to do a proper deep venous venogram, you have to put tourniquets on the leg, number one. So there's an unfounded fear of injecting superficial veins and getting tons of foam into the deep system. Number two, the flow in the deep venous system is 3 times or more as fast as in the superficial venous system. And foam, it should not be thought of as injection, but as implantation, as Karosh Parsi mentions. You have to get a critical mass of foam in a vein to induce spasm, which is the sine qua non of closing that vein. So as you're injecting foam in a perforator or a superficial vein close to a perforator, the perforator itself, this is the next point, spasms. So we get far less foam in the deep system than we think, combined with the speed at which that foam is flowing in the deep system, and you just don't get that much thrombus. And the literature bears that out, and so does our personal experience over 15 years. Thank you.
Yeah, Chris, I agree with you on that. I'm talking about the efficacy of foam for perforators versus laser, which, you know, the SECURE trial, we published And it's
Well,
a good closure. It's the best closure rate thus far in the literature using.
I've had both fail, but we don't have problems closing perforator veins of any size with foam in this practice, but albeit I do a lot of it.
Yeah.
You know what, Chris, I'm going to push back a little bit, because when we have axial veins that we're evaluating for treatment with foam, if we see perforators, that's almost a relative, if not an absolute contraindication. I've had many patients who I've treated with just minimal amounts of foam in the axial system who come back with post-op, tibial vein DVTs. So, I would say there's a lot more that goes into it, based upon, the fact that the flow is right. If you have a large 3 to 5 millimeter perforator and you're injecting foam in the axial system, you're going to get some of that foam go in the deep system. So I don't understand why, if you inject it into a perforator, it's not going to go into the deep system, or why it's not going to cause the DVT.
I don't think I'm making myself clear. Foam is deactivated in 5 to 8 seconds. Yeah, you get foam in the deep system all the time. It's just not doing anything, Peter. It's not doing anything.
Then why
and that's been borne out in the literature. And that's all I do, period. And we don't have a problem doing it. The unfortunate truth is the academic community has shirked their responsibility to demonstrate how you do foam sclerotherapy. And the AVLS is in the midst right now of trying to correct that. There's not a good description of actually how you do it, most unfortunately.
Sarah, can you unmute yourself, please? We want to hear from your UK experience, because you guys use a lot of foam in the UK, I know. And how do you feel about that with the perforators?
Not at all. I'm muted, sorry, because there's other people in the room and you might hear other voices.
That's all right.
Yes, I mean, in our practice, we have treated perforators with foam. We haven't, to my knowledge or experience, used glue to treat them. I know we have used sort of thermal ablation techniques. I think it depends on the patient. I appreciate the comment from Dr. Gibson about using the same modality for all patients, and obviously there are conversations about the suitability of cyanacrylate glue in the context of patients with venous leg ulceration and complications that can ensue from there, and that is a different matter of debate. But no, I think normal practice, we would normally use foam, but I appreciate obviously the results from the previous trials looking at endothermal versus foam, and the fact that endothermal is laser is appropriate. So I think you could have either, really. But yes, normally would use foam. I'd get here in the UK, or certainly in our unit.
Okay, Kathleen, move on, because we want to finish up here.
Yeah. Okay, so this is just showing the retrograde two-stick access. And then this is my technique for closure with cyanoacrylate for perforators. So the way I do it is I use local. There's going to be a movie, really short one. Local, his skin is like a piece of wood here. And you'll see when I get in with a micropuncture, it's very woody. In fact, I try to kind of peck into the perf. And I'm going to show you an ultrasound in a second. So the hockey stick's actually right over his ulcer. And once you get blood back, you need to flush with saline. Otherwise, your cyanoacrylate will polymerize within your needle and you can't inject it. So this is like a saline sandwich. So saline, and then you quickly put a TB syringe on. This is going to be 0.2 cc's of cyanoacrylate, and then pressure with the ultrasound probe. Okay, then next slide is, this is, let me go back. Okay, so that's not going to play. That's the perf, and I've already got needle access. Saline, and then the bright is the cyanoacrylate. And then we compress, and then this is immediately after, same area. Perf's closed, obliterated, and then, so this is before, immediately after, and at 3 weeks. That's where the perforator is. And so patient course felt better in terms of heaviness right away. At 3 weeks, his ulcer's smaller. And then this is him over the course of 3 months.
Very nice. Any final thoughts from anybody?
Oh, and after I sealed the perforators, which were one here and one down here, is I did foam sclerotherapy of the ulcer bed and then the snaky vein that was going up the side of his leg.
Kathy, did you do the foam the same day?
Yes, same day. Everything was done in the same day. This guy does not live in the Seattle area and wanted to get as much done as possible. He's actually a wine merchant. He travels around the country selling Washington wine. So he's travels a lot.
Yeah, but just to finish it up, it's not against recommendations to do everything at once in a patient with C6 disease.
No.
It's the AVF, SVS guidelines that are, yeah, you can wait, you can do the axial, see what happens to the perforators, or you can do everything at once, again, in C6 disease. So I think you can go either way on this one, do everything at once. You're looking at that leg, you want to help him out as much as you can, as soon as you can. So I agree with you, Kat.
Yeah, and my other thought of what to do was my second choice would have been laser, because I would have used a laser on the perfs and I would have used a thermal ablation on his. The reason I picked glue is you can't really appreciate from this, but his this is like he's like a piece of wood. And the idea of doing tumescence in this area, you know, both his small saphenous and the below the knee GSV was not attractive to me. Right. So that's why I picked Spanner.
Steve, can I just ask a question?
Quickly, yes. Shoot.
No, it was just a question. Seeing the veins that are still left after Kathy's injected the glue on the picture, my question is, why not just do a distal injection of foam, which would have probably got the perforator as well and would have been cheaper?
Kathy?
Distal injection of foam. Oh, instead of using a laser. Yeah, you could have, although the vein was huge down there. So I don't know. That would have been another choice.
Yeah, and just summing up, I mean, yes, you use one modality, which is great, but you also probably could have used laser for all this as well.
Yeah.
If you wanted to, the perforators as well as the axial is one of the attendees put up within the Q&A.
Introducing the VenaCure 400 Micron Perforator and Accessory Vein Ablation Kit, which lets providers treat refluxing perforator veins with the precision of the VenaCure EVLT system.
Well, good afternoon. I am Anuja Nair. Wanted to extend my gratitude to having offered us to present from our image-guided therapy group, and for me to represent the team and the colleagues here from Philips. For us at Philips, really wanted to make sure that we provided a little glimpse into some of the areas that we're thinking about, that we're looking into in terms of areas of innovation. And really the key for us is what drives our innovation is is really fueled by the unmet needs of the clinicians, of our physicians that we interact with, the space that we work in. What you're seeing here on the screen, if you're seeing my slides 2 right now, are a number of 4 different pillars, as we call them. This is really the quadruple aim for us, which guide us every day in what we develop. And these pillars are very important to us because these pillars are really what is important in general to our physicians. Again, like I said, this is fueled by the unmet needs. The ultimate goal is always to improve health outcomes for our patients. I think as clinical practice evolves, hospitals, want physicians to do more. Physicians want to do more for their patients, but yet keep costs down. And so that's an important aspect for us as well that guides us always. How do we lower cost of care? How do we then improve the overall experience for the patient, ensuring that the patient has faster procedures, lower radiation exposure, contrast load, and then as importantly, even how do we improve the satisfaction and overall experience for our physicians and the staff? Because there also we want to be able to guide improved confidence in therapy guidance, as well as reducing radiation, reducing administrative burden. We know that that has only increased in the recent years. So with these sort of guiding pillars or the quadruple aim in mind from Philips, we've been looking into a number of exciting areas, which I'm sure you have all heard of as buzzwords, artificial intelligence, augmented reality, already alluded to some of the goals around minimizing radiation exposure. And really the more important aspect here is how do we bring all of these technologies potentially to be able to provide you data in a realistic but yet very simplified manner, in a manner that is easy to understand, in a manner that is easy to act on, and improve, again, the confidence and the speed at which you want to perform procedures as well. One of the big areas for, say, artificial intelligence itself is all about managing data. In artificial intelligence, I know everybody's heard it, right? Who hasn't? We have smartphones, we have social media, it's all data driven, it's all big data today in understanding people's behaviors, looking at data from Fitbits, looking at data from Apple Watches. Data is everywhere, it's all around us. And what's most important is that for your procedures, if you're looking into deep venous space, or you're performing even other vascular procedures, you're getting data from pre-op CT, you're getting data from MR, multiplanar venography, you may be doing IVUS, and that's what you're seeing here as an example, in a demo, sort of a conceptual example here. The point is, how do we use principles of artificial intelligence, deep learning algorithms or machine learning algorithms, to extract what's meaningful and be able to present that to you in an automated manner? So imagine that with your IVUS run, for example, maybe you are in a deep venous procedure and you get an automated output of areas that you are going to look into, perhaps as in, here are the areas of interest, here are the areas of possible healthy areas of stent landing zones, and then you're able to really put that in context with venography, which you're already doing mentally, right? But we're able to provide that perhaps to you in an automated fashion. As we do that, I've used the term automated a lot. It only helps improve speed and simplicity, which then also helps reduce radiation exposure, right? So that's one of the ways in which artificial intelligence could potentially come into play in everyday practice. Another really important way is, we talked a little, I alluded to administrative burden. All the physicians we speak to have mentioned how after spending 8, 9, 10 hours in the lab and treating multiple patients, you still have 2 or 3 more hours of work to do just to make sure all the data is reported accurately, all the patient information's correctly logged. And what artificial intelligence can do there is really be able to track that data during your procedures and then be able to automatically create these reports. Of course, every physician would still need to check it, go through it, but now you have an assistant who's really doing it for you automatically, and then you get to approve or change or edit as needed. So that's another potential example of a way artificial intelligence can help. I have a video here that I will start to play, and please let me know if it doesn't come across very well. But the next area I wanted to talk a little bit about is augmented reality. What is that, right? What is augmented reality? And I have a demo here that can show you a few different concepts. Again, very hypothetical, where we think we could go. And one of them is customized flexible screens. So in the video, what you're seeing is the screen kind of follows you around. The screen allows you to direct it with voice activation, telling you go bigger or follow me. You could zoom in, zoom out of the data sets you're looking at. And it's basically allows you to interact with the data in a meaningful manner. Another concept here is representation of three-dimensional data. I mean, anatomy is three-dimensional. It's even four-dimensional, in fact, because you might be watching how a vein changes with the breathing, patient's breathing. Now, in this particular instance, you can see and spin and interact with that data set again in three-dimensional representation anywhere in the room. And the power of that is really this next concept that you're staring at, untethered control in the room. The potential, the demo that's showed here, the potential of this technology is that you are able to move around the patient table and not be tethered on one side only. And where this is really helpful also, or could be potentially helpful, is if you were to say have different access points. Say you go in jugular access point for a deep venous procedure, and then you realize you want to also have access from the common femoral. Now you're able to easily move around the patient table because the data follows you. The data and the screens are following you. It's not that the screen and the boom is only on the other side of the patient, and hence you can't go to that other side of the patient table. So this is another way in which something like augmented reality could really help improve the workflow, improve how you are interacting with the data. And finally, this is a fourth concept that I have demoed here today, and this is sort of automatic device recognition. Say these augmented reality glasses that you may have can automatically detect what ultrasound probe you've picked up. Say you want to image external ultrasound for access, to guide access, or you picked up a stent and you want to be able to recognize automatically what stent it is, what's the information behind the stent, as opposed to having to remember all that information always, or having somebody else in the room be able to provide you all that information. So putting all that together, you have augmented reality, artificial intelligence, and what you're seeing here is another rendition or another example of where you could take augmented reality, where the data is now available to you in front of you. You're not restricted to being on any one side of the table, but at the same time doing three-dimensional visualization, maybe based on a pre-op CT roadmap or MR, or even at the start of the procedure through a multiplanar venography roadmap, and now using that roadmap to truly in 3D space use technology that can show you orientation. It can show you orientation of the devices you're working with, the catheter that you might be working with, and be able to provide you information on anterior, posterior, which way you're going, and give you a sense of really what that patient's anatomy is like. Because there's a lot of variability, and this could be another way, perhaps, to improve your experience with the data and simplify that. So coming back to what we started off with, say at Philips today with image-guided therapy, we have these 4 pillars that we really want to be able to work with to drive our innovation, to be able to provide tools that are meaningful, making things easier, simpler, and really bringing you a new era of imaging with therapy guidance, and so something that's more disease specific, so it's really relevant to the disease in the space that you are in. And with that, I just want to say thank you for the attention and for again having me on here.
All right, Anuja, thank you very much. That is, I mean, you're bringing us as new as you could bring us anything. This is great. All right, thank you very much. I want to thank Philips again. Philips, one of the sponsors as well of the meeting. So thank you all. I'm sure there'll be a lot of questions to all the Philips reps about this. But thanks a lot, Anuj.
Well, I'd like to add that, everything I shared today, this is not, none of this is commercially available. These are all concepts and demos, which are really far off, and our reps probably would know nothing about.
Okay, then direct
So,
everything to
let's be-
Anuja. No, I know it wasn't.
There we go.
I know it wasn't available, but
Right.
it's nice, a nice buzz that you're bringing on here.
Absolutely.
All right, so thank you very much. We're going to move on to our next session. I know it says Tony's supposed to moderate it, but Tony is stuck somewhere, so I will be moderating, as I said before. Thank you again to Phillips. So first, we're going to have, this is on pelvic venous reflux, everybody. Moving away from the superficial to the deep. Two presenters will be Kush Desai and Mark Meisner, and our first row this time around is Chris Pitman, Edgar Guzman, and Harolder, if you're on, come on.
So we're going to talk about pelvic reflux and obstruction when it coexists in pelvic venous disease. And we are fortunate to have the authors of the largest series thus far that's published, and hopefully we'll highlight some persistent knowledge gaps. So my patient is a 56-year-old female with 1-year history of constant left groin and pelvic pain. She also has a back pain that's aggravated by prolonged sitting or intense activity. She does, when you probe her, she does have intermittent left leg heaviness, but no edema, no history of DVT. And she really, that's not her dominant complaint. She's coming in because of the back pain and the pelvic pain that she's having. And she's been told by another practitioner that she has the quote nutcracker syndrome. When I review her symptoms, she really has no flank pain. She did have a UA before she came to see me because on the intake, she had noted that, I'm coming to you because I've been told I have nutcracker syndrome. So we did a UA. She has no hematuria. She has no lower extremity varices or vulvar varicosities on an exam. She just has some scattered spiders, which are symmetric. And really, the exam is totally otherwise unremarkable. So the first question I'm going to ask for the panel and everyone, anyone that wants to contribute is, what would you do for imaging workup next? And there's a lot of different ways you can do this. Would you do ultrasound, CT, MRI, venogram, or a combination thereof?
So, Kush, before you go there, can I ask you, I know I want you to elaborate a little bit more about how this is really affecting this woman.
Right.
How does it affect her life? Give us a sense of that.
That's a great question. And, it's important not only to get that information, but using that information to appropriately counsel them on expectations of a treatment. She's an avid runner. She exercises a lot, and this is impacting her ability to exercise, and it's a big part of who she is and her identity. So that's a part of it. She doesn't have dyspareunia, and that didn't seem like a big deal to her, but it's getting harder and harder to get through the day.
Okay, so that my point, and everybody, the point is she may have nutcracker, but how bad is it affecting? You're telling us it is. So
that's right.
Okay, we get it.
Steve, can I ask one question? I probably missed it. Kush, did I see how many pregnancies she's had and how old she was?
She's had 2 pregnancies and she's 56. I didn't put the pregnancies on here.
And presumably postmenopausal.
Yes.
So an elderly demographic for this problem.
For this problem, correct.
Well, we don't know what the problem is. Somebody told her she has nutcracker.
And Kush,
correct.
Okay.
Kush, this is Peter. Has she had previous abdominal surgeries or any other GYN history?
No, she had normal vaginal deliveries, no C-sections, really pretty
no history of fibroids, ovarian cysts, or any other gynecologic potential problems?
No.
Okay.
I didn't specifically ask about fibroids. I did ask about her GYN history, and it's about as unremarkable as it can get.
All right, so Kush, for these questions, is this one of the questions the audience can answer?
I don't think I submitted it in a way that they brought it up. So this is more if somebody wants to pipe in from the audience or for the panel.
Okay, so hang on. We thought ahead. So Mike, just get ready to put up the A, B, C, or D, Mike, but not yet. So for those of you who are going to be voting, we're going to put up a question that says A, B, C, or D. So A will be CT, A will be ultrasound, B will be CT, C will be MRI, and D will be venogram, and we're going to have to skip the combination thereof. So for those of you, we're going to put up A, B, C, or D. A, ultrasound, B, CT, C, MRI, and D, venogram. Go ahead, Mike. And whenever you want to put up the answers, Mike, whenever they come, just let us know. I don't.
Okay, ultrasound. And, you know, that's a great place to start. We've talked in many of these meetings ad nauseum about the variability in ultrasound, and it's not an excuse, but it's a reality. Abdominal and pelvic ultrasound at some centers, even at very, you know, experienced and high volume centers, is not always great. Pelvic ultrasound, you know, certainly from a GYN perspective, you can see parametrial varices. A lot of these women have had transvaginal ultrasound, so you can see parametrial varices in those, and then lower extremity ultrasound as well. But you know, as Nicos has talked about, and Mark as well, you can see the ovarian vein pretty easily if you know what to look for and how to find it on transabdominal ultrasound. But what I wanted to highlight is that since so many of these women have been through sort of the rigmarole, the pathway of seeing multiple providers, they frequently have imaging that's already been done. And so my first step is to say, well, what have you had done already? And let's look at that so we don't just reproduce cost and time and effort that may be totally unnecessary. So she's had a CT before. This is not a CT I ordered, and it's not the way I would work it up, but she had a CT before, and I bring it to your attention that it does look like she has that bird beaking, that compression of the left renal vein that you see here. But is this significant? And we'll certainly discuss that some more. And then when you look on the CT, these are coronal reformatted images, you can see that the contrast column within the left ovarian vein is extraordinarily dense, and as dense also in the parametrial veins, as you see on the image on the right. This is basically a 90-second delay portal venous phase CT. So to have that much contrast and that dense of contrast from the left ovarian vein, this is clearly refluxing and not emptying at a normal rate. So probably physiologically significant. And you can find this information. It's not one for one, but it is for many patients, this information is already present. So
Kush, can I ask you a question? I mean, I think you can get a lot of information about a CT that I wouldn't get it primarily, but if you have it, are there other signs that there may be some renal venous hypertension? Like, are there some ascending lumbar collaterals, some adrenophrenic collaterals going up? I think it's really important to look at what the collateral pathways are from the renal vein when you look at this to know if this is likely hemodynamically significant or not.
Yeah, that's a great point. So, you know, we've talked about it before. When somebody has a renal vein issue that is very hemodynamically significant, certainly invasively you can do pressures, but on your non-invasives, particularly on axial imaging, you can look for a collateral drainage. And although I don't have images in this presentation above this level, you often would see a large phrenicoadrenal collateral that then connects to the azygous system here. So, which she doesn't have. So she doesn't have the secondary signs, but those are all things you want to look for. Occasionally you might see a delay or differential enhancement of the kidneys. The left kidney, if it's truly hemodynamically compromised, is not going to be emptying at the same rate as the right kidney. And so the contrast might be dense or hypodense depending on the phase of imaging that you have. But you can see here, and I don't have these images, it also looked like she had a left iliac vein compression. I'll remind you that in her symptomatology, she did say, when you pull it out of her, she's like, yeah, my left leg does hurt, but that's not why. I mean, I have terrible pelvic pain. That's really her issue. So we're thinking we need to do a procedure for her. We have this non-invasive imaging. She is on the older side of the demographic, as Mark pointed out. But we think we can help her. So we'll go on to talk about what our approach would be. And this is probably hard to adapt to a question for Mike, but we can ask the panelists.
No, we could just ask the panel. So Edgar, if you're going to interrogate her ovarian, renal, and pelvic system, what access would you think you want to do here?
I'd probably go from the upper body, either IJ or brachial, basilic, cephalic, anything in the arm would also give you that downward angle, and the catheter length is not excessive. Coming from there, I would probably use an MPA as the catheter to select. And
okay, so Edgar, not everybody's an interventional radiologist. On this, the 200 graded people who are listening, talk to us about what MPA catheter is, what that stands for, or somebody.
Sure. So what an MPA catheter is a catheter with an angle tip and a fairly long tip at that. It's roughly 2.5 to 3 centimeters long. So that choice of catheter becomes important in the cava because the cava can be fairly broad, like 2.5 centimeters. So by using that tip, you can have the catheter hug the opposite wall, in this case the right, and have the tip go far down enough to where you can engage the ostium, and as you advance your wire, have the support of the vein wall. With a smaller catheter, you just find yourself floating and you have a lot of wire outside the catheter trying to engage the vein. So that's why the MPA would be a good catheter there. When coming
especially for the right ovarian.
Yeah. When coming from the groin, you have to use usually a reverse curve catheter to get that downward angle, and then you end up having to use something rather big like a sidewinder even, or something to get enough length to achieve that effect of hugging or getting support from the opposite wall of the vein you're trying to cannulate.
Yeah, Chris, thank you. I think that helped everybody. Chris, what's your access of choice when you're looking to interrogate the renals and the ovarian?
I'm old-fashioned femoral, common femoral vein access.
And what catheter then do you use? What reverse catheter do you usually is your go-to?
I generally start with Teflon C2 catheter and a glide wire.
All right. You guys want to talk about any other catheters here, Tony? What's your preference?
I kind of, if it's just the left ovarian, I just use a Cobra. Very easy to get into. I just reform it in T12 and just drag it down, and it just pops right into the left ovarian, into the left renal.
Right.
If I'm going from the neck.
For the people who don't do this, you're coming from the groin for that.
Correct.
Yeah.
If it's if I have to do left and right or just right, then I go jugular using a combination of MPA catheter and an Ansel 1 to give me even more of an extension to engage that right ovarian.
Okay, go on.
Okay, and I want to make sure that we hear from Mark about balloon occlusion because I like how he thinks using a balloon occlusion catheter. But we can talk about that when we get to the actual embolization part of this. So I typically like to come from the groin. Is just the way I was trained, and I was trained to do varicoceles and female pelvic venous disease with a gonadal guide catheter. It's a 7 French. You literally cannot keep it out of the gonadal vein, or the ovarian vein in this case. It's 7 French. I put an 8 French sheath. I do GSV access for virtually all my cases, like Steve and many others. And then I put a 5 French glide catheter through this. So here's a left renal venogram. And Mark, what do you see here? I mean, it looks like a congested hilum, right?
Yeah, I mean, you have hilar varices, you have that adrenico-phrenic branch going, phrenico-adrenal branch going up, and then you have some collaterals going, some lumbars going back into the IVC. So that suggests renal venous hypertension there.
Okay. So this is where I think there's a little bit of controversy. I agree with you that the imaging certainly suggests it, but her symptoms don't necessarily fit it, right? She doesn't have the flank pain. She doesn't have hematuria. She has symptoms that are more consistent with, uncompensated ovarian reflux.
Yeah, and if you put a catheter in there, you're probably not going to find a gradient with there. If you put a balloon catheter in the ovarian vein and measure a gradient, you'll see the pressure with the balloon occlusion probably go up to 9, 10, 11, 12 if you occlude that ovarian vein.
Right, right. So this is the pop-off, and the reason why she developed is she may indeed have if we're going to use the terminology nutcracker, she may have a left renal vein compression, but that's compensated through ovarian reflux over time.
Can I ask something?
Sure.
So is the image that we're seeing done with an injector or it's hand injection?
Hand injection.
And Chris, the other thing I'd like to see on the image is, it followed down into the pelvis and just see how, if you look at the old criteria.
There you go, Mark.
Great. Any dynamic images?
I don't have any videos, I don't think, on this, but it is stagnant in the pelvis.
So the other thing, or Mark may be saying it, is if it's a gradient, usually it transits quickly to the right side and goes up quickly, and if it's reflux, it sits. Is that what you're going to say, Mark, or I'm interrupting?
Well, you know, if you look at the old Beard criteria, it talked about 20 and 40-second cutoffs for stagnation in the pelvis, and it seems to me that if it's a true renal vein compression, you never see it stagnate for 40 seconds, like in the old Beard criteria.
Right. I mean, part of this is that I have a 7 French catheter in there, so I'm undoubtedly getting occlusive in the ostium of the left ovarian vein. But all this contrast goes and stays in the pelvis. Very little of it goes back into the renal vein here, but it's hard to tell. Ideally, you would have probably what you do, which is if you wanted to test for that, which is come from the neck with the 5 French catheter, and then you're not occlusive, and you can really make that determination.
Well, and I like to see it from the renal vein injection to see, you know, not selectively, but look at the pelvis when you inject the renal vein, and if
well, that was the previous one, right?
Yeah.
But
yeah.
But you didn't see the pelvis with it.
Yeah.
Well, but you can see it's probably going down there, Mark. I mean, that's
pretty
Yeah.
dense, the contrast going down.
What I'm saying is you want to see a pattern of drainage when you inject from the renal vein.
Mm-hmm.
Yeah, I don't have that image for you. In fact, I'm sitting next to Pax. Maybe I could pull it up, but
Oh no, you don't have time to pull it.
I know.
Let's
But
move
you
on.
can even make something up, Kush.
Yeah.
it goes all the way to the pelvis, dynamic.
So just looking at this picture, Alan Davis is asking, you know, how do you know that the ovarian vein is not an internal escape vein? And if you treat the iliac outflow obstruction and preferentially have flow go away from the ovarian, this reflux will be asymptomatic and probably go away. Actually, that's Peter's comment.
That's Peter's comment. That's a great, I mean, Peter's the one that wrote the paper, and I haven't shown you the iliac vein obstruction, but I guess we'll just show our cards and say that.
Can I just comment on the fact that if you just treat the left ovarian vein and you have got a proper physiological nutcracker, I've seen people who've had their left ovarian veins embolized who've ended up with worse symptomatology. And actually there are a cohort that should actually just have a very simple left ovarian transposition, which actually I accept as a surgical intervention, but actually that way you treat the nutcracker and the left ovarian reflux.
Yeah, I mean,
much we don't.
All right, so there's many ways to skin the cat. Move along, show us what you did.
Okay, so here's what I did. I selectively catheterized deep into the left ovarian vein, and then I did foam sclerotherapy. We'll probably skip over this panel question, coils, plugs, approach to foam. What I did is I typically do 3% STS foam with CO2. I have that CO2 commander. So I do literally a milliliter of 3%, and then I foam it with 10 cc's of contrast and rapidly go back and forth. And it gets a really nice foam. You worry much less about that theoretical risk of non-target embolization or an air embolism. And you get a really nice thick foam that comes out of it. Some people put gel foam and Lipiodol. That's all fine. And then we followed up with coils. This is the point in the talk where Tony obligatorily tells me that I use too many coils. But they're pushable coils. They're not that expensive. They're 12 millimeter nesters. So we put some coils there, and you can see on the final run, and just as a comparison for Mark here, that image on the right is just a renal vein catheterization. You no longer see reflux down into the left ovarian vein. So we've treated in this one. I did check the right on her. I don't have the images. It was not refluxing down. I didn't do what Mark advocates for, which is get deep selective with a balloon occlusion up in the right ovarian vein to see if there's varices down. And I think there is value to doing that, but I didn't do that in this patient.
But Kush, when you did your foam sclero, did you do a balloon occlusion and then do the foam, or you just got your catheter all the way down?
I just got I put contrast in there, and then I noticed I noted the volume of contrast I needed to fill the varix, and then I just put that amount in.
So what happened after this?
Okay. So we interrogated it. We interrogated the right ovarian vein. There was no reflux, no evidence of varices. And then we did a run in the left renal or the left iliac vein with no intention to treat it this time, but just to document what we see. And you can see that there's a compression. You don't need IVUS at this point. Of course, we'll use it if we do treat it, but there's a compression, there's pre-stenotic dilation. You see this median sacral vein here. So this is a compression. But again, that wasn't her dominant complaint. So we're not going to treat it all at once. And we can certainly go into whether we should treat it all at once or not.
No, but also you don't have many branches refluxing in the internal here. And no. You told us that her symptoms really were more pelvic, not leg.
Correct.
Right,
Correct.
so of course.
So we left it alone. And we just said, we'll see you back in a little bit and we'll reassess. She's discharged with some NSAIDs. She returned at 1 month for follow-up. Her symptoms have now progressed. They're worse, as Dr. Davies suggested they may be, but is it really, it's not flank. It's all in the left groin and it's still in pelvic pain. And the pelvic pain is now more severe than it was before. So I'm beginning to think that it's uncompensated ovarian reflux and compensated iliac vein compression. It's a dual source here.
And
so now what? I again asked her about her leg. You work out a lot. Tell me about the leg. And she's like, well, if you keep asking about it, yeah, it gets heavy, but that's not really why I'm here. I can run like 5 miles, not a problem. I said, okay, well, I'm beginning to think we need to, we'll look at everything again, but we need to probably think about placing a stent. And I don't take placing stents even in someone her age lightly, but that's where we were sort of ending up at. So we planned for a left iliac venogram and an IVUS. And here's the IVUS, and that's the compression site right there. Pre-stenotic dilated, completely out of the field of view, and then the reference normal external iliac vein. So even by video criteria, this is a significant IVUS compression at 61% on the diameter. So IVUS confirmed the compression, and then we placed a 14140. This is a Venovo stent that we placed, and the only hemodynamic change you really see is you no longer see that median sacral vein here anymore. And we had her come back.
Is that how I usually put a stent?
Yeah, I was just going to ask that. I want to see your post-IVUS venogram. It seems a little into that vena cava.
This is the contralateral wall.
Okay, but where do you like to land your stent into the cava if you just have iliac compression?
So here's
half a centimeter or what?
About a centimeter or so.
Centimeter, okay.
Yep, about a centimeter, because you don't want, you want to be just past the compression site with about a couple millimeters to spare. So it ends up being about a centimeter, and it really depends on how steep or
it depends on the angle of the thing.
Yeah.
It looks high, but it depends on what the IVUS.
Let's see the IVUS. That'll show us.
So here's the IVUS.
Yeah,
IVC.
Yeah, good. All right, good. Then that's good.
Right. I'm not sure I could have placed it differently.
No.
No, I think it's really tricky to nail it. I mean, if you I think it looks perfect because it's really hard, and then you hate to have to put a second stent in if you miss it.
Yeah, because then you introduce that second mechanical failure point.
Exactly.
No, I think this brings up the point that an image is not as good as IVUS, and you use the IVUS to plan your placement of your stent.
That's right.
And so people should take that away, in that the image looked like you were too far in, but you weren't too far in because you measured prior with IVUS where you wanted to land it, and post-stent with IVUS, you landed exactly where it is. It's not too far into the vena cava.
Yeah, one thing I've learned is, and we can talk about this in the other deep venous sessions in more detail, is your imaging parallax when you take your initial image, especially if you're magged out and the center, the cranial extent of your stent is not in the center of your field of view, it's going to look funny. So what I typically do is, with the IVUS catheter, mark exactly where I want the stent, and then I mag up, and I just put that in the center of the field of view, and it looks a lot better.
Exactly.
Kush, the other trick there is often the image is slightly rotated, and it makes you look like you're further over to the left. So even with parallax plus a bit of rotation, you've got to account for all of those to make that final image look like you're spot on. The IVUS looks perfect.
Yeah.
I agree that the venogram might look a little bit too far to the left, but it's not.
Something that I like to do that help me land more precisely, because when the IVUS tracks the wire, it starts kind of looking up as it crosses the bifurcation, and that makes you look a little bit higher, is I like using a reverse curve catheter and hooking the bifurcation So I form it, get on the bifurcation and pull it down onto the apex of that bifurcation, and then I just draw a line in the screen, and that gives me a sense of where the bottom of the bifurcation is. Another guideline to
that's another
try to get that stent.
All right, so Kush, what do you got? So we can move on to the.
Yeah.
Can I
So
ask Bishop, I think there's an important question though, before you get to whether, did you look at the internal iliac veins selectively before you put your stent in?
I had on the first procedure, I didn't put those images in. I didn't see anything that was refluxing significantly from them.
Did you put an occlusion balloon in and look at it?
I knew you'd ask that, and no, I didn't.
You know, one of the problems I've seen, not in a handful of patients, is, you know, if you have big varices down in the pelvis and you stent the iliac vein, and some patients don't get better, and you come back and they have big varices in their pelvis, and then it's very painful to try to get through the interstices of the stent and come back and embolize those varices.
And then microcatheter work, and yeah.
And I admit it's a minority of patients, but it does happen.
Yeah.
And so I think it's really important to look first, just in that handful of patients who, just because you're setting yourself up for a world of,
Hurt if you don't.
yeah, of trying to get back through the stent interstices to embolize any varices.
You can always go from the other side, Mark.
What?
You can always treat something from the other side. And in this case, the fact that she got worse after embolizing her reflux, you know.
All I'm saying is you ought to look.
Yeah.
But also, Mark, with the newer stents, that the interstices are quite big, aren't they? So, you know, Venovo and a upraised stent, which are now, you know, Venovo is on label. You can get quite a lot through the sidewall of that without any problems compared to a wall stent.
Can you get an 8 French catheter through it?
Yeah, I would think so.
All right, let's go. We got to keep
All
moving.
right.
We got
So the happy end of the story, her left groin and pelvic pain resolved. She did have the obligatory back pain after these on-label stents. We're seeing it virtually with all of them, even if it's sized appropriately. Occasionally we have to do a Medrol dose pack in some patients. Luckily, I don't oversize too much personally, and I've not had somebody with permanent pain. After her back pain was gone, she was completely asymptomatic. Complete response, actually much more than I had hoped for, and not something I tell my patients to always expect. So her left leg, which wasn't really bothering her, was also improved as well. So I have additional sides. We'll skip them in the interest of time. It's just the review of the data. Thanks for your attention.
Yeah. So this is the one question you have here. Would you do something differently the next time around, Kush? You yourself.
You know, I don't think I would, because if you look at Peter's data, which is the largest subset so far, when they staged it, they still had a greater reduction on the visual analog score than when they did it simultaneously. And that's the only data we have yet. I mean, we really need to study it.
So can I give you some more data?
Sure.
Go, Peter.
So we submitted an abstract to the AVLS where we looked at 82 women who had exactly what you had. And of those 82 women, we had 6 months or greater follow-up on 30 of them. So what we did was every one of those women got stented and none of them got embolized. 24 out of the 30 women went down to a 0 on their visual analog pain scores. The 6 that had, 4 of them had improvement, 2 of them had no improvement, and of the 2 had no improvement, 1 of them had a labrum tear on an MRI. Then we asked, well, of those 30 women, how many of them had a pelvic reservoir? 12 of them had a pelvic reservoir by venography. 7 of them got better just with the stenting. And in the improvement group, there were 5 of them who had still a pelvic reservoir. So there is a subset of women who have a pelvic reservoir who get improvement with stenting, but not complete resolution. But of those 4 women who had improvement, none of them wanted to come back for an embolization because they were improved enough just with the stenting. But 80% of the patients who have both an ovarian vein reflux with a reservoir who got stented had complete resolution of their symptoms.
All right, thank you. All right, thanks a lot. Kush, thank you.
Thank you.
And we want to thank Medtronic again, another industry partner of Expert Venous Management here. So thank you. Again, without the support of industry, we would not be doing this at all. So we thank them. Mark Meisner, you're up next. Ovarian reflux with no pelvic symptoms.
Thanks, Steve. Okay, so I'm presenting a case of a 51-year-old. She is premenopausal, who comes in with bilateral lower extremity aching, heaviness, and focal tenderness over varicosities. Sort of a typical story, exacerbated by standing, worse throughout the day. Hasn't had much improvement with compression stockings, and she has virtually no pelvic symptoms whatsoever. Her past medical history is notable for 3 pregnancies. About 20 years ago, she had bilateral great saphenous vein stripping, which helped her for a while, and then she's had the gradual return of these symptomatic varices since that time. Has a family history of a father who has varicose veins. And on her exam, it's got no edema, no skin changes. On her left lower extremity, she has varices over the medial aspect of the distal thigh and proximal calf. And on the right lower extremities, and I didn't have a picture of her right side, so I borrowed this from one of Kathy's papers, but this is pretty much what she had, is 5 to 6 millimeter varices over the proximal medial thigh. So I think I'm not going to give a question now because I think everybody would probably do an ultrasound at this point. And this is what her ultrasound demonstrated. On the left side in the mid-thigh, the great saphenous vein is 7.4 millimeters and has reflux. Junction isn't refluxing, but reflux below it. And on the right side has junctional reflux. Her saphenous vein, consistent with her previous stripping, is absent. I'm not quite sure what they stripped 20 years ago on the left side, but her saphenous vein is still there. And on the right side, there is a large varix that courses from the proximal thigh and communicates with the native great saphenous vein in the calf. And this seems to have a pelvic origin. There is some reflux at the saphenofemoral junction with a small cluster of varices at the groin, but that doesn't connect to the visible varicosities at all on ultrasound. So first question is a premenopausal woman with symptomatic recurrent, at least on the left side, on the right side, sorry, pelvic origin, medial thigh varices, has no pelvic symptoms. First question, what's your choice of what to do at this point? Cross-sectional imaging, duplex ultrasound of the abdomen and pelvis, go straight to venography, or just go straight to treatment? You have the question, Steve?
Mark, you gave us the answer.
Oh, I did, sorry.
Okay. We know the answer. So let's ask the panel. Would that have been your answer? Edgar, would that be your answer?
Yes, trying to track those veins up as high as possible and getting a good look at the gonadal veins, and if possible to see anything transabdominally around the uterus, or if not transvaginally at some later point.
Chris?
I just proceed to treatment.
Yeah, okay, we'll discuss that. Go ahead, Tony. What were you following the case, Tony, or you just?
Yeah, I would do an ultrasound too.
All right, so can I be the Chris and I will be the devil's advocate. Mark, you're absolutely 1,000% sure there's no pelvic symptoms.
Absolutely no pelvic symptoms.
So why are you looking into the pelvis?
I want to know how big her variceal bed is in the pelvis.
But can't you find that out when you do the Rosenblatt treatment method?
You could. I guess I'd like all the information. I'm probably, as you can guess, I'm more of a more information person than a less information person.
Well, I'm not as smart as you. I can't handle all the information at once. I try and the least possible to get the job done. I'm joking. So,
and besides that, you're the one who gave me this topic, so I
right. Kush. See, we ask interventional radiology. Although Chris, you didn't look above. Kush, what would you do here in this patient?
I would do an ultrasound. I mean, especially no pelvic symptoms and these varicosities. Yeah, you want to try and trace it up.
May I respond why I wouldn't do it?
Yes, of course.
because 15% of ladies have enlarged veins on on CT scans. It's homologous, as we all know, to male varicocele. 15 to 20% of guys are going to have a varicocele, whether symptomatic or not. Of course, guys, maybe a fraction have symptoms from it. I used to have one, by the way. And then, of course, it's a leading cause of male infertility. In ladies, it has the exact same incidence, but only a fraction of women have symptoms from it. So I don't see how, there's so many ladies with pelvic venous insufficiency, I don't see how imaging up there is going to make any difference to your treatment. Thank you.
Well, except for I would say this patient really isn't asymptomatic from her. She has no pelvic symptoms, but she's symptomatic from her pelvic veins. I mean, these are coming down to her leg. And I would say, to me, it's a little bit analogous to saying, well, this patient is coming in with calf varices, but I'm not going to look up in their thigh to see where these are coming from.
That's tenuous, isn't it?
That doesn't preclude you from treating the lower legs. It's the same thing I would state with, are you going to look in the iliacs and stent somebody before you do lower extremity treatment? Most people would say no.
Right.
But
nobody want to know.
All right, I'm going to take prerogative as moderator. Stephen Black, weigh in, and then we're going to move on.
Yeah, just as, we have an endemic of treating pelvic veins because once you start looking, you're going to find something. That's the old adage. If you scan somebody from head to toe, you're going to find something you have to deal with. If she's totally asymptomatic and you start off treating your veins, you get a successful treatment, you're all good. If it doesn't work, come back and imaging your veins later. I'm just not clear on why the additional information makes a difference now.
Yeah, that's where I'm going with that too. But okay, there's different ways again.
Okay, and let me, can I just play the devil's advocate and say?
I already played the devil's advocate. You have to play some other advocate.
How are you going to treat this patient's left leg?
The left leg. The
right
left
leg.
leg.
Sorry, right leg.
The right leg is the one that has the varices from the pelvis, right?
Well, it seems to have an origin from the pelvis. Wasn't looked at.
So I would do a combination of either phlebectomy if the veins are big lower down, but then fluoroscopic guided foam sclerotherapy of the inner thigh veins and fill all the way up, hopefully, to the internal iliac system. You know the technique, and then see how much dye it took you to fill it, and then put foam in that same volume.
So I would suggest that depends. I think it's advantageous to know you have varices up in the pelvis to do that. Otherwise, you could just do phlebectomy.
No, it's not a big deal. I mean, it's a minimal stick. Go ahead.
We did it anyway. And you can see she has quite large varices around the uterus, has pretty good left to right flow transpelvically. Her internal iliac veins are a little bit generous, 1 centimeter on both sides, but both of them don't demonstrate, both of them have antegrade flow in them. Here's the right side. Her left ovarian vein measures 8.6 millimeters and does have reflux. Her right ovarian vein is larger, measures just a little over 1 centimeter and does not have reflux. So you do see periuterine veins. Right ovarian vein measures 1 centimeter, no reflux. Left ovarian vein, 9 millimeters, no reflux. No internal iliac vein reflux. You do see some flattening of the left common iliac vein, but it dilates with a Valsalva and does have some anatomic compression of a renal vein, but it doesn't meet criteria for hemodynamically significant compression.
So I rarely agree with Mark, but I can't believe how many people on this panel are resistant in getting an ultrasound when every patient with any type of pain and having the information for me, you're going to treat the patient. But it does help in discussion with the patient about what to tell them as far as expectations as recurrence and stuff. Plus, if it's completely normal and there is no pelvic disease, if they go somewhere else, they'll know that information beforehand when they're told they need 4 or 5 procedures. So I just am surprised that ultrasound is really so resistant to evaluate a disease process that's coming potentially from the pelvis.
Yeah, and I would say even if you don't want to get a formal ultrasound, it is, if you're scanning the patient personally in your office, preparing to do a procedure on him, it adds 2 minutes to it to have them lay down, look suprapubically yourself and see if they have varices there. It's just,
May I add a comment? This is Chris. When you're a foamaholic like I am, it just doesn't matter. If there's a pelvic source, I'm going to inject foam in those veins in the upper thigh, and I'm not going to have a problem. And that flavors to a large degree my opinion.
and how much foam are you going to inject?
Doesn't matter because it's gone in 5 to 8 seconds, Mark.
Well,
okay. How do you know you injected enough?
Right. Yeah. See,
you want it controversial, right, Steve? But it doesn't matter. I use ultrasound. We do labial varicosities, groin varicosities. Doesn't matter. You use ultrasound.
I mean, I do think I'm in between both of you. I would not have looked above. I would have treated from below. But as I said, I would have gotten an idea about what type of volume I might need to fill that pelvic venous bed by doing a fluoroscopy first.
Don't need
Mark, keep moving on. Is this what'd you do, Mark? Move on.
Okay, so which leg are you going to treat first, Steve?
They're both equal?
Yeah.
I know, you could toss a coin.
Doesn't matter.
I would do the left.
And what intervention? So we did treat the left first just because it was.
Oh my God, we agreed. Oh my God.
Yeah, and just did radiofrequency ablation and phlebectomy. And I gave you the answer again because these are the slides I sent in. So what now? I don't think anybody thinks that you need to further evaluate those compression lesions. Those are just anatomic. So the real question is, are you going to treat these from above and treat the unilateral or bilateral ovarian veins first, or go and just treat the legs? Why don't you pull the panel, Steve, since I gave the answer?
Okay. Tony, from below or above?
From below.
Chris, we know what you would do, from below. Edgar.
I would just wait and see how she does with what we did.
No, would you treat from below on the right side?
Oh, from below, sorry.
Yes, okay. And so would I. Now, somebody does have one question, speaking about treating from below, is what's the recurrence rate if we do this from below and we have ignored what's happening above? Anyone have any data on that? Maybe.
If you look at Michelle Perrin's data, it's 18%. If you look at Mark Whiteley's data, it's somewhere between 25 and 33%.
Right.
I was going to guess 10 to 20%, and I think it depends on how old the patient is and whether they have more pregnancies. If they have more pregnancies, they get recurrence.
Shoot.
Can I say something a little controversial?
Yes.
This is
going to be the last controversial thing, and then we're going to go to the next.
Why are we so obsessed with recurrence when foam is so easy to repeat? And if somebody does get recurrence of 20%, it doesn't really matter if you think that coiling from above reduces the recurrence rate to 5%. Why is that a worthwhile thing to do when foam is easy to repeat and you probably get a good result the second time round?
I don't think that's controversial at all. I think that makes sense.
Yeah, it seems to be controversial, pushing this idea of recurrence.
Vein disease is an incurable disease. We know that. It's all about setting the patient's expectations when you start to treat them. And I do think then maybe that's a reason to get the ultrasound only to set their expectations. But let us move on. Mark, thank you very much. Thank you, panel.
Oh, we haven't got to the end yet, Steve.
Oh, you're not? Oh, I thought this is it. We know what you did. Go ahead. Shoot.
So we did sort of what Chris says, although I like to do it with fluoroscopy, sort of the Mel Rosenblatt approach of puncturing the veins, doing a retrograde or an antegrade venogram, and calibrating the volume. And you can see you can nicely reflux the contrast all the way up into the pudendal vein and that dilated internal iliac vein, and treat that with foam and make sure that you've got spasm, just like Chris was saying, the sine qua non of successful treatment is spasm. The only way you're going to see whether you spasm those veins is with fluoroscopy and that you've gotten the right volume. And then we did phlebectomy of the leg varicosities.
Oh my God, very nice. So you did exactly what I said I would do.
Yes.
It's very scary, Mark, very scary. We agreed on the management of this.
He's coming around slowly, Steve.
Yes, yes, finally. All right, thank you all. Thank you, panel, very much.
This is industry supported, but they didn't make these slides. They just asked me, this is Medtronic's industry supported session, to share the hypersensitivity data that I presented, I guess it was last year or the year before at the AVLS. So I am a consultant for Medtronic, but this data was not supported by them and it was not funded by them. This is just data from our practice. And we were looking at hypersensitivity in patients with cyanoacrylate. And I've got a little bit of information too that's after we published our paper on this. I'll also preface, questions will probably come up about granulomas that have been reported with venous seal. We have not seen any yet in our practice, so I can't comment personally on prevalence of that. We've now done, as of this month, about 500 treatment days with cyanoacrylate. So when our first introduction in our clinic to cyanoacrylate was the VCLOS trial. And during that trial, we did notice that some patients developed a self-limited cutaneous dermal reaction, and we called it superficial thrombophlebitis, but it was actually quite unique, and it's different than what you see with phlebitis from endothermal procedures. And when we did another clinical trial that was investigator initiated in our practice called the WAVES trial, we looked for it specifically and defined it differently than superficial thrombophlebitis. And it is a cutaneous dermal reaction that occurs within the first several weeks that is itchy. That's one of the hallmarks of it. So a study that we did in our practice was to look at overall at all of our patients treated with cyanoacrylate, and because we tracked them to see what the whether there were any identifying factors with hypersensitivity. And so the paper that we published was 367 limbs over 304 treatment days. We now have 500 treatment days. I don't have all the data for that. I'm going to present you the 304 treatment day data. So our definitions were that hypersensitivity is a distinctive dermal reaction with erythema, itching. Sometimes there's edema. There may or may not be pain. We defined mild, and here's a picture you can see. This is actually a physician I treated. She's got this kind of red splotchy look. would either require no treatment or over-the-counter treatment, and we typically for that use antihistamines and non-steroidal anti-inflammatories and sometimes a topical steroid like triamcinolone. Moderate, and here's a picture of a moderate reaction marked with these little black dots of where the spread is, that would require prescription steroids, and severe we would define as recurring or lasting greater than 30 days or requiring removal of the vein. So we divided the patient into three eras. The first one was when we were doing clinical trials only. Second was post-approval, but before we obtained CPT codes. And the third was after CPT codes were available. And so this was our grouping of our patients. And so we wanted to see how these groups were different. And we wanted to see with what we had learned about trying to screen out patients who are at risk for hypersensitivity, did our rates decrease? And there's some technical changes we've also made in how we recapture the glue tip and make sure that we don't have any glue in the subcutaneous tissue. So for the whole total study, this was what we had. 40% of them were C2. You can see that only 3% of them, 11 patients had an ulcer, and mean BMI was thin, age 54, VCSS mean was 7, or median was 7. We treated mostly GSVs, but a smattering of other veins. The mean diameter 6.8 with a range of mean diameter of up to 11.5. Largest segment treated, which was kind of an aneurysmal segment, was 24, and the mean volume 2.1 for cyanoacrylate. So we had 18 total reactions, so 6% total of all of those patients. 4.3% were mild, 1.3 moderate, and 1 patient did require vein removal for recurrent symptoms. So interestingly, we never had a patient who had hypersensitivity when their second limb was treated on a different date. So a lot of questions people have had are, do you sensitize people to glue if you treat one leg and then another? And in this study, we didn't have anybody that with their second limb treatment on a different date had hypersensitivity. The severe reaction was a lady that got rash 3 different times. The rash itself was not severe when she had it, but we did send her to an allergist, and she was allergic to all adhesives. And the segment of vein that we had closed was in the thigh only. And we excised it with ultrasound guidance, tumescence, and small incisions, and her problem resolved. So the mean onset of when hypersensitivity usually occurs is about 13 days. And here this shows the ranging from day after to 23 days out. And the mean duration is just over a week. We found that there was a trend towards decreased hypersensitivity by SEEP class. This was in the paper that I published. And what we found with more data is that this is becoming it's becoming less of a trend, and we think that it's confounded by age, and we think that age is more important, that we're now finding that the older demographic, so over 70, for example, the Medicare age group, has a lower incidence of hypersensitivity, and that might have been confounding this. So we tend to now think that it's age and not disease class that makes a difference. But in the paper I published, we found no difference in hypersensitivity by gender. Age, here we didn't see a difference, but now that we're treating a lot more Medicare patients, since this paper was out, we're finding that age seems to be driving it, and not 65 and under versus 65 and older, but kind of the more elderly group over 70 doesn't seem to have much hypersensitivity. There was no influence by BMI, VCSS, size of vein, or volume of cyanoacrylate used. We found that our hypersensitivity was highest in the time after the clinical trial, and then came back down after in 2018, a little lower. So here's our newest data that we kind of peaked with hypersensitivity reactions in 2017. And in the last couple years, our rate has been going down, and there's a few things that we're doing differently that I'll describe. So ages by era, we've gotten so that we have older patients now, and that we are treating more advanced SEEP classes now than we were in clinical trials. BMI has not changed a lot. It's changed a little bit. And so what we're doing differently now, and why we think that we may be having lower hypersensitivity rates, is we are asking everyone questions about adhesive allergy, about whether they are allergic to Band-Aids and artificial nails, artificial eyelashes, anything where they've had potential adhesive allergies. The other thing that we are doing is that we are waiting a full 30 seconds after the last injection before removing the glue catheter, and we're resheathing it. So what I do in my practice is I pin the glue catheter, unscrew it from the blue sheath, and push the blue sheath back over it to recapture it before I remove it. Another technique that can be used is to use a 7 French sheath initially and pull the glue catheter into that so that you ensure that the glue is never in the subcutaneous tissue. We do some patch testing. This has not been validated, and I'll show you a positive patch test here. So this is a woman, there's a black Sharpie mark on her arm, but I've put a spot of Venus on it. This is 3 days later, it's turned red and itchy. So this is a person where I would not use Venus. And again, this is just what we do. This has not been recommended by Medtronic. This is just what we do in our practice. So our data may be skewed that we've become a lot more diligent about tracking these events over time, and that early on, we sometimes were calling hypersensitivity phlebitis and vice versa. And again, skin testing hasn't been validated or studied. So overall in the study we did, 6% of patients had some sort of reaction. Our rates now are around 2 to 3%. The majority of cases are mild and self-limited. We've had one patient that required vein removal. This was not for a granulomatous reaction. This was for a recurrent rash. We didn't find any in my paper predictive factors other than seat clinical class. However, now I think that probably age is what was driving that, and it was probably confounding that. And that we don't seem to think that having cyanoacrylate once makes you more likely to have it or sensitizes you. And again, skin testing has not been validated.
All right, thank you, Kathy. Thanks for that. And you can share your screen. But we also want to thank, again, Medtronic, one of the people who are helping to bring you this meeting, because again, without industry support, none of us would be here. So once again, thank you to Medtronic. Also, we want to thank Radcliffe Vascular, who is doing the entire technical support for this and have coordinated everything. So once again, thanks to Radcliffe. We're now moving on.
Any questions for Kathy by any chance from anybody?
Oh yeah, that's it.
Kathy, very quickly, what do you say to your patients, particularly the younger ones, before you choose to treat them with the glue?
So anybody that I treat with glue, I also offer them another alternative. You know, I don't ever tell them that this is what they need to do. It's an option. Oh, I have to start my video again so you can see. I'm unminimizing myself. I do let everybody know it's a permanent implant, like if they had a dental implant or, you know, had an artificial joint or anything like that, that this is something with them permanently. And I do share with them, my hypersensitivity rate is higher, in particular in people under 40. So I do share that with them. I also show every patient that chooses to have cyanoacrylate, I show them photos of what the reaction looks like. And I ask them to call us if that occurs, and I get them started on over-the-counter medications. I don't prophylactically put people on that. If they start having symptoms, they do, and then within 24 hours, we touch base with them again. And the vast majority of them do well with over-the-counter medication, but if they find after 24 hours their itching is increased, then I don't hesitate to put them on a quick Medrol dose pack that's 5 or 6 day steroid taper. And again, that knocks out the reaction in most everyone else.
Thank you.
Mm-hmm. You're welcome.
That clarifies. Okay, thanks a lot. Again, thanks to Medtronic. So let's move on now. This session is going to be on patients with wounds. And Tomasz Urbanek will be moderating this from Poland. And as our panel, we have Alan Davies, Manj Goel, and Bill Marston, who is going to give us the first talk.
So I call this case, that leg don't look right, because that was what the nurse who saw the patient and did the intake the first day is referred, that was her assessment. So this patient was a 61-year-old male, and I'm sorry to say for Mark Meisner, who totally destroyed his Harley in an accident about 7 years prior to me seeing him, and sustained extensive orthopedic injuries, pelvic fracture, multiple long bone fractures, had about a 2-month hospital course, multiple orthopedic procedures, DVT during the hospitalization, and had an IVC filter placed. Other medical history was pretty unremarkable, except at the time we saw him, he had been diagnosed with some congestive heart failure, but it was pretty well managed, not severely symptomatic. He had developed severe right leg post-thrombotic syndrome with ulceration, and more mild left leg post-thrombotic syndrome with some swelling, but no ulceration. He'd had the ulcer on the right leg for about 9 months, had been around at multiple other clinics, most recently at a clinic that I work with frequently for about 3 months. And you know, when patients come from other wound clinics, you sort of categorize them. Some of them, really all they do is put different goops on. They never really try to get to the root of the problem, and you start over with them. But this clinic was a pretty good one, and I usually find they do good wound care, and so we don't necessarily have to start over with them. This is what the leg looked like, and you can see they've been doing some pretty good compression, but there's still some edema in the leg. Now, the upper leg was really massively edematous from just above the knee up to the groin. And when I came in the room, I said, well, that doesn't look so bad. The nurses said, well, the problem is over here on the lateral side of the leg. And so this obviously was not doing very well. So we started with our venous duplex. And to summarize, this was the findings of the duplex ultrasound. The right popliteal vein was partially compressible with high velocity reflux. Femoral vein was non-compressible and was retracted. There was decreased phasicity in the right common femoral. And the tech noted that it was difficult to compress due to the patient's body habitus and the massive swelling up in the upper leg and groin. But there was wall-to-wall color filling. And we didn't see any significant saphenous, either great or small reflux. So my first question then, let me show you the common femoral waveform. I thought this was interesting. It certainly doesn't go down to baseline and reduce phasicity, and that's what it looked like. So my first question would be, what to do next? And I think I submitted this as a question, Steve and Tomas.
Yeah, here it is.
I think that we should try to answer this, but you're right. To proceed with this case, treatment without any further diagnostic procedure will be not possible. So let's check the answers and if we can vote.
So 1 would be CT or MR venogram, 2, venography with IVUS and intervention, 3, filter retrieval, 4, more wound care and bandaging, or 5, hyperbaric oxygen. Time to vote.
And Bill, are you just able to confirm that the patient did have good compression therapy and was compliant?
Yes, yes. He had been having multi-layer bandaging done weekly with changes in between that at home for probably 3 months.
Okay, so the answer is mostly chosen is CT or MR venogram. Probably most of us would like to plan the procedure before, to know something before we put the patient on the table. Do you have the results of this CT or MR venogram?
Yes, I do. So this is the CT scan, and we'll show a couple of different things as this goes through. So first thing to look at is as we come up, the femoral vein is small and retracted up through here as you move up. And you also notice really some massive varicosities in the subcutaneous tissue, but the saphenous itself was not enlarged. And you can see the femur shattered and really abnormal. And then some really large varicosities right up in the groin. The common femoral, though, was pretty normal caliber. And as we move up into the pelvis, the left iliac was pretty much occluded. But interestingly, there really was not that much swelling on the left leg. The right leg, though, had a pretty normal or even enlarged looking iliac and common iliac. And then you see up in the vena cava, the filter with occlusion at the filter, and then reconstitution at the renal vein. Any questions about the scan? Huge subcutaneous varices.
So where's the finish of the occlusion? Where is the, I mean, this is all the below the renal vein occlusion, yes?
That's correct. It was normal above the renal. And so right at the filter, and then normal looking iliacs and common femoral, but severe disease of the femoral below that.
Okay, there is the question: do we need IVUS for any reason now, or just to go to the operating room and to try to perform phlebography IVUS and to recanalize? What was your idea?
So I guess the question would be, how many would get the filter out? And if so, would you do it by itself first and then come back later to open the cava, do everything at once, or what?
How old is the filter?
Filter's been in for 7 years.
Let's go first, Manj. What do you think here?
So the first thing I'm thinking is we need to manage this guy's expectations. You've chosen a horrible case for us, Bill. But this guy, even if you get everything open and running, you know, he's going to have lymphatic damage. He's going to have, you know, we don't know about his cardiac status. A lot of these people may have cardiac issues. So I would be managing his expectations. I'm not sure whether the extent of filter removal recanalization is going to be worth it in terms of risk benefit, but that might be just my conservative British attitude.
Yes, but the patient is already after many months of the conservative treatment, which is unsuccessful, which is a huge ulcer. This has for sure an influence on the quality of life, but also do we have any other ways to treat the patient if this is really the case of severe venous obstruction with the venous hypertension, which in reality can be corrected in a endovascular way, even without the filter removal, because we can go with this stent through the filter and try to recanalize, at least try to do this.
I'll just make one other quick comment, if I may. I have several patients in this sort of situation where I've just focused on the ulcer, the sort of the Ron Bush subulcer foam sclerotherapy approach. Clearly, this guy's got lots of other things going on, but I think that would be a relatively low risk thing to do to try and promote some healing. But I appreciate you're up against it here.
So what I'm going to
wait, Bill, first, Kush, let's hear from a radical Midwesterner, and then maybe we'll hear from another conservative UK person in Alan.
Well, for those of you that know me, I think that when you don't remove the filter in these, even though there's some data to suggest you can pave through it, the largest set of patients where they paved through the filter and displaced with the stent had about a 12 to 15% reintervention rate at 30 days. So I think, and certainly Steve Black could talk to this as well, I think that it can affect expansion of the stent, which then affects your lumen. So if possible, it's not always possible, but if possible, I'd like to try and retrieve the filter, and it's going to depend on local expertise and whether you can do it. And Bill has that expertise with him and he himself and his colleagues at Carolina. So I think if you can, you should retrieve the filter. And then I think recanalization can make a big difference in this patient's life, but we're studying that prospectively right now through a randomized trial.
I 100% agree with Coach there.
Sorry.
So I think, Steve, I would probably agree with I'd agree with Steve and Kush. I think we probably would think about doing something to ensure that you've got good central drainage. I think my only question is how far up, is there much disease above the IVC filter? I would just quite like to see some further imaging, but I also agree with Manj. I think there's quite a lot you can do locally, but I think we would probably think about stenting, but probably we would probably try and stent and leave the IVC filter there in our experience.
Yeah, the IVC is pretty good up above the filter. And I'll show you some more images of that in a minute. Now, we have plenty of patients that, for whatever reason, we haven't been able to open them up centrally, and we manage them in the wound clinic. And, you know, you can oftentimes get them to heal, but they have a high recurrence rate, and they, you know, don't tend to be as functional as those that you can open it up. So we went ahead to try and get this open. And I've generally done these with the rule that if the filter takes more than about 2 hours to get out, then I usually stage it. If they come out real quick, then we go ahead and open things up. Also, sort of depending on how hard you have to pull. If it's a real lot of torque you're putting on it, I'd rather give it a little time to heal before I dilate the cava or the iliac vein. So this patient took a good while to strip the things off of the top of the filter, but eventually we were able to get it and go ahead and extract it. My colleague Bob Dixon from IR is really excellent at this, and he's the one who did this work. But it did take about 2.5 hours, so we decided we would give him a few weeks or so and come back and recanalize after that. And that may not have been a good idea because his wound got infected in the meantime, and he was admitted to the hospital. And interestingly, he also had an exacerbation of CHF that they tuned up. But during that hospitalization, the medical service ordered a venous duplex to rule out DVT, as they like to do. And the tech, one of our experienced techs in the hospital, said, you know, the flow in the common femoral is retrograde. And she says, I think there's an AV fistula that is driving some of this pressure in the femoral vein. So my question to the panel is, what would you do with this?
But this is the picture after the intervention of the filter removal, yes?
Just the filter retrieval, yes.
Okay, so I think that if the femoral spectrum changed and we see a suspicion, at least suspicion of the fistula, I think after such an invasive approach, it's time to repeat the imaging study with at least CT venography to see what happens, because in my center, we wouldn't like to remove 7-year-old filter. We probably will go through with the recanalization and stent if possible, but congratulations for the 7-year-old filter removal, but probably something happens. So do you have any imaging of the abdominal vessels at this moment?
Well, I think if you go back and look at the prior common femoral vein waveform, it's the same as this. I think that it was just inverted.
But Bill, you didn't go through the groin to take the filter out, did you? So
no, this is all done through the neck. There was no groin
exactly. So I mean, I kind of, you've had a bit of good imaging, but it doesn't, you know, sometimes you see this with really high volume flow out of the leg, and which is quite difficult to tell if it's a fistula or not. But even if it is, if your plan was to stent his IV, that's a good one, because with a fistula into a block system is going to be even worse. So sometimes these resolve themselves when you deal with the outflow obstruction.
And so we got a CT angiogram, and our radiologist thought that this showed evidence of a fistula in the hypogastric artery to vein. There was higher contrast density in the right hypogastric veins compared to the left. They said it was difficult to say for sure, but that's where they thought where the fistula was. Probably chronic from his injuries from his motorcycle crash. So what would you do now? Would you go ahead and intervene on the obstructed right femoral vein, intervene to open the IVC, both of those, do an angiogram to identify and think about embolizing the fistula, or hyperbaric oxygen?
And, you know, while people are answering, one one thought just to echo what Steve said. That right leg is almost certainly hyperdynamic because it's draining the left leg. And I think on the original CT, you showed this large, cross pelvic, almost like a saphenous to saphenous bypass collateral. So really that right common femoral vein, it's almost the size of the IVC at the inguinal ligament. And it's probably handling the deep venous drainage for both legs.
Right, because the left is obstructed.
Completely out, right?
Yeah, I agree with that point of Kush. Plus you're adding in the added complexity of somebody's getting a recurrent infection in their leg with the lymphatic drainage and all the obstructive symptoms. So all of those processes together make it difficult to interpret that as a static image to prove it's, and you can't see a big fistula. So even if it is, it's small. Otherwise the scan would be obvious.
So one question we thought a lot about with his history of CHF, if we open his IVC and all of a sudden he's got a bunch of flow, are we going to exacerbate that and cause problems?
I have seen it a few times. Twice I had patients develop flash pulmonary edema, and the anesthesiologist was convinced that I had thrown a PE. I said, there's no PE, it's chronic. There's nothing with embolic potential here. But nevertheless, they get a CT and you see that they have pulmonary edema. So it's certainly something very worthwhile thinking about. And in a couple patients where they have at least a cardiac history that's known to us, we get echoes beforehand so that we can at least have that in the back of our minds if the patient starts decompensating.
So it can be interesting. We had one patient that was sent to us with an occluded IVC and iliacs with some heart history and sent by the cardiologist, and he was getting syncope, pre-syncope that they thought was from lack of afterload when he would stand up. And then after we fixed him, that went away. So interesting case.
Well, we thought because of his recent exacerbation of CHF from the last hospitalization that we should go ahead and initially embolize that AV fistula, and it wasn't easy. You can see the flow into the IVC, and this is an injection on the right into the iliac vein, and you can see all the flow is retrograde. You really could not get flow to go up from the external iliac. And so, again, my IR colleagues actually took 2 sessions of about 3.5 hours each to do multiple embolizations. They said it was really more like an AVM than just a single fistula. You can see a bunch of branches. And after 2 sessions, they had it improve, but I wouldn't say it was completely resolved. But you can see here, they're out into the branches, and you don't see so much flow into the IVC anymore. So then a few days after they finished, we came back to reopen the IVC. And this really was, certainly for someone like Kush, this is a walk in the park, because from above we could get down into the segment where the filter was. From below, we're only a little over 1 centimeter apart, and it wasn't too difficult to pass through there and open that up. And this is what it looked like on injection. We, of course, did IVUS as well. And then a single Venovo stent, and opened up pretty nicely.
Nice case.
Very nice. Just one question regarding this embolization. Did you observe any changes in the femoral vein flow after the embolization? So the question is, what was the real significance of this fistula, arteriovenous one?
I can't tell you if there's a difference. You mean in the venous flow? The femoral vein flow?
I thought if this was any significance of this fistula, because in reality closing such a fistula in such a hyperdynamic circulation is quite difficult, as you saw us. It's a number of vessels which were enlarged, but the result is perfect. Thank you.
Well,
I think the interesting academic question is, if you'd have not done the IVC stent and just seen the result of embolizing the fistula, how much different would that have made? Because that could have been driving a lot of the venous hypertension with that retrograde flow.
So, and that's a great question. I'll just show you these pictures so you can see there has been improvement. And this is probably about, 6 weeks or so. And his leg is really much, much smaller. This is about 1 month out. He's coming back 6 weeks, 2 weeks from now for his post-op duplexes. So we'll be able to look at, Tomas, your question. We didn't, wait after doing the EMBO to do so I couldn't really tell you the difference there.
Hey, Bill, this is Tom O'Donnell.
Hey, Tom.
You've done one part of the trifecta, if you will, i.e. reducing the venous hypertension, but you've still got to deal with the abnormal lymphatics, because this is really a case of phlebolymphodema and the wound itself.
Yeah.
How are you planning to treat the lymphatics in this patient?
Well, I think he's definitely somebody that probably will benefit long-term from a pump.
Right.
Because, as you said, that it doesn't all just decompress right away. I said there's been a lot of reduction in his edema, but still in his upper leg, it's still very edematous. But I think we've gotten to where the wound can heal, and then you get a lot of other options. You can get your MOD therapist to start to work on him. He still has some residual fistula, and we'll probably get another session of embolization in a few months with Dr. Dixon.
So are you going to let the wound heal in, or go ahead and do a split thickness skin graft to cover it?
We'll see how it does over the next 3 or 4 weeks. I mean, it's really been healing pretty rapidly already. And so I think it'll heal without it.
The Venovo-venous stent is a self-expanding nitinol stent that is specifically designed for the venous anatomy. It is available from 10 to 20 millimeters in diameter and 40 to 160 millimeters in length, and in 80 and 120 centimeter catheter lengths. Each stent features 3 radiopaque tantalum markers and 3 nitinol markers on each end. Each end is also flared 3 millimeters to ensure adequate wall apposition. The Venovo-venous stent is loaded on a triaxial over-the-wire delivery system. The catheter is comprised of a guide wire lumen, stent delivery sheath, and system stability sheath. The stent is constrained in the space between the guide wire lumen and the stent delivery sheath. The guide wire lumen originates proximally on the handle with a Luer hub and terminates distally at the catheter tip. The guide wire lumen is compatible with an 035 guide wire. The delivery system handle includes 2 deployment thumb wheels. The large thumb wheel slowly retracts the stent delivery sheath during stent deployment. The small thumb wheel retracts the delivery system sheath faster during stent deployment. The red safety lock slider on the handle helps prevent unintentional stent deployment.
We want to thank BD Bard for also supporting us here. And happened to be the stent that Bill showed us in the case that he just did as well, serendipitously. But again, without industry, we would not be here. So BD Bard, we thank you very much for all your support.
All right. Well, if this conference was a brewery, I think, we're now to the light beer part here. I don't know anything about procedures. I get invited because this is about expert venous management, and diagnosis is really the first component of management. And it's what I'm going to talk about here. I have 2 cases. If I can get through the first one in 11, 12 minutes, we'll do the second one here. This first one is about 5 doctors and 5 different diagnoses that come from it. Now, the patient I want to tell you about is a 28-year-old female, and the case begins clear back in 2012. She goes and sees her university doctor because of some pelvic pain. They obtain a CT scan of the abdomen and pelvis. She has clearly a ruptured ovarian cyst. This seems to fit the clinical picture, and indeed, given some time, her symptoms resolve. What's noted, though, incidentally, on this CT scan is this nodule over here in the right inguinal region. And the radiologists interpret this as a 1.5 centimeter, technically indeterminate, but probably reactive, prominent right inguinal nodule here. Their confidence level, in fact, of this diagnosis turns out to be 100%. She does great for about a year, and then she begins to develop some off and on band-like pain across her abdomen, just below the umbilicus. She comes back in to see her doctors, gets another CT scan. This time, the scan is completely negative. And true to form, the CT is curative because shortly afterwards, her pain disappears. What's interesting is that, again, incidentally noted, she's completely asymptomatic here, is this exact same node 18 months later, still 1.5 centimeters in diameter. So maybe not a reactive node, but it's still there. Well, I can sense the excitement building here. She gets married. She moves out of her university town into a small town, gets herself a small town doctor at a small town hospital. And 4 years later, living in this small town, she developed some flank pain, which her doctor thinks is probably passing a stone, maybe some pyelonephritis. He obtains a CT scan, which supports the diagnosis. They see a stone, they see a big ureter, but incidentally noted, yeah, look at this over here. How's that? Indeterminate lesion in the right groin adjacent to the right great saphenous vein. This lesion may be vascular in origin or less likely a lymph node. Well, if that's a lymph node, it's the mother of all lymph nodes there. Notice that, again, she's completely asymptomatic. These nodes and this mass are completely unknown to her. I'll just give you a couple other views from that same CT study. In cross-section, this was about 4 to 5 centimeters in diameter, depending on where you looked at it. And we don't really know the length because we never saw the distal extent of this cutoff lesion. All right, well, I did provide a question. I don't have the question
Michael put
here,
up a
but
question. Here it is.
What do you think should be done next here? Do you think we should follow this lady clinically? And if it's stable, just repeat another CT in 3 months, maybe with some better views? Or should we do an ultrasound now? Or should we do an MR now? Or how about, do we want to biopsy this mass? Or do you just want to surgically remove it? Or should we do something else? Those are your options.
So can we vote?
Yes.
Yes.
Okay, can we see the results?
Don't rush the technology.
All right, well, why am I not surprised? Ultrasound always wins, and that's exactly what happened. They took her for an ultrasound. She got in the next month. I put down here, it's kind of an interesting study. It was done at because they had the word vascular on the CT report, they said, well, we should get it done by vascular people. Well, there's a little non-accredited vein center type facility in the area. They sent her there, and they did this ultrasound where they noticed a large, heterogeneous, hypoechoic mass-like structure that they could see up there is 2.5 by 4.5 by 6 centimeters. And they felt that this structure most likely represented a thrombosed aneurysmal segment of the great saphenous vein. The local doctor, armed with this information, was now 100% confident that this was the diagnosis. Although the patient did have no history of any trauma or intervention ever happening on that side. Kind of curious.
Tom, can I ask you a question?
Sure.
Of the panelists as well. So here at our hospital, we have a, actually like 25, 30 years ago, they started with the whole cytodiagnostic center here, and they'll stick a needle into anything, and most of the time really give you a diagnosis, a great majority of the time. When the biopsy was the choice here, I would not do something open, but why not a fine needle aspiration of this? It's very benign and sometimes can give you, most of the time, give you the answer.
Yeah, absolutely. I would not have done an open, to me, an open biopsy would have been no different from the next option, which was just surgically removing
before you start the biopsy and the invasive approach, what about color Doppler ultrasound of this lesion to see if this is any vascularity inside? This is first question. Second, do we have any data about the entire length and course of this saphenous vein? Because this probably will have some value regarding the final diagnosis.
Right. Both excellent questions, and neither of which I'm able to answer. Again, this particular study didn't include any color imaging, and it was done at again, a small facility far from here, unable to get additional information. Well, hearing that she had some kind of a vascular aneurysm, she wanted to go back and see her university doctors again. So she went back to the university that she was formerly affiliated with and saw a vascular surgeon. So that's doctor number 3. Even though it's only been 3 weeks since the last ultrasound, they thought, well, let's get a real ultrasound. This is in our accredited university vascular lab. And I guess it's a good thing they did, because the doctor agreed, yes, there's no flow in this thing, but this lesion has some diffuse low-level internal reticulated echoes. They're talking about, in particular, this area back here. And along with this area, they also noticed a vessel with some high flow in it that was coming up and abutting against this. So their conclusion was that the little lab almost got it right, that the mass in the right groin was actually a chronically thrombosed saccular aneurysm arising from a small branch of the right common femoral artery. So thank heavens we got the proper thing done. And their confidence level in this diagnosis was at least 100%, maybe more, if that's possible.
What about Tom, this is Tom O'Donnell, knowing your background, did anybody consider this might be a lymphocele?
As far as I know, they didn't. I would have thought about the possibility of a lymphocele, but
another reason to stick a needle into it.
Another reason
to
have stuck a needle into it. I think that wouldn't have been a bad idea here.
Yeah, I mean, the weird thing is that, I mean, usually a arterial aneurysm would be painful in a person her age, or she would notice it, right?
Yeah,
so I mean, I don't buy it.
Especially after it grew from a centimeter to 6
she would, it wouldn't be asymptomatic.
And the other point is that lymph node that you kept pointing out more proximal, I presume it's on the same side, correct?
Correct. In the same proximity. So they actually had wondered if this might be an expansion of it originally.
Why don't we just ask Nico to give us a diagnosis?
No, because
Tom, this one in the picture we see there is no direct connection from this image between the artery and this mass that looks like to be an aneurysm. Okay, there is a compression of this little artery. It looks like you see the Elias, you see the main arteries and the little artery. There's the mosaic color, so there might be compression from this mass over the artery.
Yeah.
If there was a connection within, we should be able to see flow actually inside the aneurysm, and we don't. If the artery had high flow because it's feeding this mass, it should have been, seeing all the flow inside the aneurysm. We see nothing of this. So I think it looks like to me it's independent of this little artery, it's something else.
All right, well, you argue with Nico at your own risk. Just remember that.
Tom, this is Peter. When you press on it, does it compress, or is it a solid mass?
It feels like a solid mass.
So it's less likely that it's a lymphocele if it's a solid.
It feels solid, at the very least, I'll call it rubbery. All right.
Shouldn't
Well,
be there, so it's got to go.
There, well, you think so, but maybe not. She goes back after her university consult, visits her with her local doctor. He says, well, you know, what the heck, arteries, veins, they're the same thing, aren't they? You know, all I know for sure is we got to follow this thing up. So she needs some follow-up imaging. Now, you know, it turns out that ultrasound didn't really sort this out as well as they'd like. So he decides that when he follows it up, he's going to get an MR because that'll give you more additional information, right? He sends her to a little private imaging place where a couple of radiologists in the community have a CT scan and an MR, and they do this study, and sure enough, there it is. This is it 3 months later. Looks a little smaller, but in my experience, every vascular lesion always looks smaller, tighter, whatever on an MR. So I'm not quite sure what to think about it. Well, later in the afternoon, the doc gets a call from the radiologist who does the study, and she's all excited. She says, thank you for sending me this patient because this is fascinating. She says, I know what this is. She says, this is a T1 hyperintense cystic mass. It's got these thin septations in it, and it's definitely involves an accessory part of the great saphenous vein. This is venous cystic adventitial disease. I think all the vascular surgeons here for sure are familiar with cystic adventitial disease that we see in like the popliteal artery. Rarely it is reported in veins. And she says, this is highly suspicious. She goes ahead and obtains the university vascular surgeon's ultrasound, and when she sees that, she says, oh yeah, this is a slam dunk now. See these things that they were talking about, these septations back here are actually diagnostic of one of these cysts. So this is almost a case report. It's such a fantastic thing. I don't know if any of you have seen them. And Tom, you talked about a lymphocele. This is a very rare variant. Her confidence in this diagnosis is 100%. Well,
so about
yes.
16 cases reported on the veins with cystic adventitial disease, one of which is actually Tony Gasparis' case on the external iliac vein.
I love it. Why am I not surprised, Nicos? Hang around if I could do this second case, because I'll need you for that. So 100% confidence. Now, here comes the part where you cannot make this stuff up, okay? I don't make these cases up. This is how they actually happen. 1 week after she gets that MRI of the pelvis and gets this cystic adventitial diagnosis, she develops acute neck and shoulder pain. It's actually been coming off and on for months, but it acutely worsens. She goes back to the university where she sees neurology. They get an MR of her neck, and that's what she's got. Well, this requires urgent surgery. She's pretty symptomatic from it. So they take her into surgery, and this turns out to be a nerve sheath tumor. The surgeon who takes the tumor out reviews her case and says, oh man, I have seen this before. These things, you get them in the spine, but you can also get them in the groin. I'll bet she's got another one in her groin there. His confidence level is 100%.
God, stick a needle in it.
So I'm going to give you a quick summary and then we'll end it here. We got an unknown mass in the groin that's been there for 8 years. It is completely asymptomatic. She has never had one symptom from this. And if anything, it might be getting a little smaller or stable in size. This is when they thought it was just a node back then. This is this big mass they saw, but now based on the MR, maybe it's a little bit smaller. So my question, I don't care how we could do one of these, but you know, you can either put them up or I can, you know, read it up. But what do you guys think this is? There you go. Give me an answer. Do you think is this a big lymph node or a pseudoaneurysm that's arterial or a venous pseudoaneurysm? Or is it cystic adventitial disease of the vein?
Tom, it's almost not possible that within 8 years in US, no one put the needle inside. You have aggressive medicine and it could happen. So the question is, when you saw this patient, did you send this patient finally to any fine needle biopsy or something like this? Because probably there will be so many answer as a point here, but
yes, I'm just curious as to what you think, and I will answer that question in the next slide.
All right.
All right, so we got a kind of a nice split here. Nobody knows what it is. Well, the patient comes now to the Mayo Clinic system, and you can see what's in Dr. Number 6's hand here. This is the patient wanted this thing out. So we didn't even run any other additional tests. We just took the darn thing out, and that's what it looks like. What is this?
Who knows?
Adventitial cystic disease.
No, that's
looks like a nerve sheath tumor, right?
Good job, Tom. That's a thrombosed venous pseudoaneurysm right there.
Yeah.
So our little country doctor with the non-accredited vascular lab actually nailed this thing when the others didn't. And I have wrestled over this case. I don't know how to explain it other than, and this is what I'll bring to this group here and ask your opinion. She did have this 1.5 year history of a, quote, inflammatory lymph node that was right up against the vein in that area. Now, we see tumors and big lymph nodes all the time, lymphomas and cancerous nodes. And, you know, we asked today, has anybody seen a venous pseudoaneurysm from ablation of a vein? Has anybody seen a venous aneurysm like this develop from nodal erosion into a vein? Because that's the only thing I can think of, is that, you know, did she have a node that eroded into this, a low pressure bleed that she didn't sense, didn't feel, didn't hurt her, but it wound up walling off and creating this thing?
I never seen such
for that to have happened, if it's an erosion, then you would have a different. This looks like it's, or histologically would answer that. This doesn't look. This looks like that's a normal vein wall that's dilated and big, rather than a false aneurysm type of appearance.
That's
what does the histology look like?
It's a great point. I did not look at the histology myself. The pathologist reported this as a venous pseudoaneurysm, so I'm assuming that there were some elements in the wall that you know, weren't 3 layers of enema, media, and adventitia.
So do you think the color flow examination retrospectively might have helped way back when?
Yeah, obviously. I think, you know, a color flow at the time when it was noticed to be, you know, the first time it was noticed to be that big lesion would have probably solved everything.
Do you think sticking a needle in it would have helped?
Would have helped. Although in this particular case, we'd have probably gotten nothing.
Yeah.
No, they would have gotten something.
Could have ruled some stuff out, but I don't know that you would have diagnosed. If you stuck it in when it was thrombosed, you'd have gotten some clotted blood back.
Yeah, exactly.
So what was your radiology bill?
But Tom, we saw some static images. If you go with the ultrasound up and down, you should have seen the defect on the vein. It should be easy to make this diagnosis. I've seen a case like that from a screw on the clavicle that injured the subclavian vein and make a pseudoaneurysm on subclavian vein. That's the only case I've seen.
Mm-hmm.
And you should have been able to, with the, you know, follow the saphenous and the connection with this on ultrasound. But the amazing thing is that it took 8 years for somebody to take this out. And I've reviewed a bunch of malpractice cases for tumors that were just followed with ultrasound, and they were just getting bigger, and nobody, you know, at some point, you know, you're going to miss something if you just continue to just ignore it just because they're asymptomatic.
Excellent point. It's one of those cases where I just thought it's so real world. This is what we see, you know, in referral practices all the time, that it's just fascinating and worth looking at one.
Okay, once again, we want to thank Organogenesis. Obviously makes a lot of products for wound healing that we use in our vein world, but other products as well. Again, without Organogenesis and everybody else, we wouldn't be able to have this. So thank you. Tom, finish it up with one of the easier cases you've ever presented.
Yes, here we go. Great, great, great. All right. I don't even know if I believe this case. Nicos, are you out there? Because I need you. This case, I thought about you from the moment I first saw it.
Okay.
It's recurrent leg pain and swelling in a runner. And this particular case starts in 2016 with a 51-year-old man, excellent health, no significant past medical history, and he's a runner. He runs about 5 to 10K every day. He has long-standing varicose veins just over the front of his left leg here, over the left tibial region. And in 2016, they were getting a little bit bigger, a little more tender. So he went in and had them removed, just a little local ambulatory phlebectomy. The results were excellent. There were no complications. Healed and went back to running. And most importantly, his symptoms resolved completely. Now, he did well for about a year. And then he had one particular run where he developed leg pain afterwards. His doctors said, well, I think this is shin splints. It was kind of anterior leg pain, but he did have a little bit of posterior leg pain. And it was leg pain, I should have put it here, in that left leg where he had this removed. Now, again, to sort of cover all bases, even though it was 3 days out from the onset of pain, they did just screen him with a D-dimer. And lo and behold, it was up. This was considered a significant increase in D-dimer. So they went ahead and did an ultrasound, which was negative for DVT and SVT. They weren't sure what it was, assumed it must be shin splints, and treated him with nonsteroidals. And sure enough, his pain resolved over the next 3 to 4 weeks, and his D-dimer, for whatever reason, normalized. I don't know why it was up, I guess. Well, Steve likes musical references in all of his talks. Britney Spears did it again, and this guy went ahead and did it again. The next year, he's out running. It's about 10 months after that first episode, goes for a slightly longer than his usual run, and once again develops acute onset of left anterior tibial pain. Now, when you examine him, he's got tenderness and localized swelling over this mid-tibia and some mild calf tenderness. And he gets another D-dimer done, and sure enough, it's up. So they do another ultrasound, and it is 100% totally, completely negative for any DVT, SVT, any other clot. They get an X-ray thinking maybe there might be a stress fracture or something that could be playing a role. That comes back normal. So the question is, what do you do next? I only had 2 things here. I mean, are you going to work them up more at this time? It's a second episode. Or are you going to do what you did the first time and just say, well, lay off it, let's let it heal and see what happens? They went ahead and did the second option. They said, let's watch it and see if he gets better again. Well, this time he didn't. He didn't get better. After 5 days, he actually felt a little worse. There was still some swelling and tenderness that was worse right over this anterior tibial region where he'd had his original little vein resection done. There was some trivial erythema and swelling, so they decided to get an MR at this point. I don't read MRs at all, but what I did was I highlighted the tibial bone here for you so you can see the tibia.
All right, Tom?
Yeah.
Before we continue, I want to ask,
go ahead.
Manj or Alan, anyone have a working diagnosis in their mind yet?
I wonder, I think there are two things going through my mind, whether he's actually got an underlying venous malformation or whether he's actually got a popliteal venous entrapment syndrome.
Manj?
So I was going to say popliteal venous entrapment as well. I think with the persistent swelling, it'd be good to exclude a venous outflow obstruction. I mean, the D-dimer is so non-specific. Is there a nerve issue from his previous phlebectomy?
No one's considering anterior compartment syndrome or anything like that?
Was there any swelling during this pain or just the pain in the anterior?
Little bit of swelling, slight swelling.
Mm-hmm.
And
well, Your MRI would make the diagnosis of entrapment.
It would.
Well, no, not really, because it's unless it's dynamic. Because I would have thought you'd want a duplex to do that, Tom.
Yeah, but I think it's more likely your first diagnosis, Alan.
No, I think I would agree with that, but we'll wait and see.
Yeah.
Okay, these are tremendous. All three of the diagnoses you've thrown out, I think, are just wonderful. He had the MR, and as I say, there's the bone for those of you that aren't, used to looking at it. Right in this region is where his pain and tenderness is. You can see under the skin a little inflammation here and a little bit of venous space. He's still got a few varicosities that you don't see, but within the bone marrow in this area, there's also some inflammation. Now here's where the case gets interesting. We could go down a bunch of rabbit holes. I wanted to bring this particular thought to this group and see what you think about it. I have shopped this with no less than a dozen of the best bone radiologists that I could find. And here is the overwhelming consensus on this case. I'll show you this MR here. There is an interosseous venous branch that connects with the tibial vessels. I'll show it to you in cross section here. You can see right here as it runs through the cortex of the bone. Down a little lower, this particular branch actually moves into the marrow space. And then at this level, it exits through the bone into the anterior surface. This is where his where his varicose veins were and where they were resected from. Now here's where it gets interesting. Do you think this vein ever thromboses? Because what we did, we think about this, we have superficial veins that thrombose. We have deep veins, proximal deep veins that can thrombose, tibial veins that can thrombose, muscular veins that can thrombose. Well, here's sort of a drawing. Here's a drawing of this interosseous branch with its connections to the various tibial veins here. Does this thing ever thrombose? Well, I posed it to our radiologists. I showed you that MR obtained just about 5 days after the onset of his pain, and their conclusion, based on everything they can tell about veins, is that they think that this interosseous vessel is clotted. So they can't find clot in any of the other veins, just in this interosseal vessel. I initiated a DOAC, rescanned him 9 weeks later, and I have to take their word for it. I don't know, but they assure me that this vein has now reopened and that it is a little larger and more distended. In other words, they think the clotted interosseous vein has recanalized, and at 9 weeks, the D-dimer is normal. It's normalized. Now, I went back through the literature, and I can find the reports of 13 cases of intraosseous varicose veins, but we don't know if these are primary or are they secondary. Are they veins that occurred much like this guy's, where an interosseous thrombosis occurs in somebody, it recanalizes and leaves them with what's considered a painful intraosseous varicosity. I couldn't find any cases of acute varicose veins, and if you think, or of acute thrombus. And if you think about it, it would be very hard to diagnose. It's difficult to see with ultrasound. There's no real good way to do a venogram and get contrast into these things where you can see it. MR is probably your only hope, and it really hasn't been validated or tested. I just threw this paper in for the last slide here, because this gives us an idea when you see isolated below the knee thrombi. In this particular study, about 60% of them were in the deep or the tibial veins, and the other 40% were in the muscular veins. But I have to ask myself, how many people have I seen with unexplained bouts of leg pain that we never work up? They're often athletes, or they have some trauma or something, and we just never figure it out. It goes away. Have I missed this diagnosis in the past? How common would it be for this particular vein, this interosseous vein, to thrombose and cause problems? So that's where I'm gonna leave this case. I'm wondering if this isn't, for me anyway, a new diagnosis that I may rarely have to think about, but not necessarily know how to always diagnose.
Very, very interesting, Tom. I think
Tom, this is extremely rare. We see occasionally intraosseous veins in normal people and people with varicose veins are benign. There's nothing wrong. We used, not me, but previous generations, they used to see them when they used to do this, intraosseous phlebography.
Mm-hmm.
But nobody has commented or reported a series of cases with symptomatic thrombosis in these veins. I mean, extremely rare, I must say.
Well, do you think, is it extremely rare, or do we just
or
really
missing
don't
it?
have a way to diagnose? Maybe it's common.
But Tom, what do you think the actual cause is, and why you were getting the vein recurrence, or is it just that after one set of avulsions, this patient developed a thrombosis in this vein?
I don't know.
Do you think this vein is actually the primary cause, or is just a secondary event after an intervention?
Well, or I wonder if it's not in some way related to repetitive trauma associated with running. Would a runner in between times when they're not running and they're resting, do you traumatize these bones at all? Do any of the things that we consider stress fractures or something set up some type of inflammatory response within the bone that causes the vein contained within it to clot?
Tom, I think this is a great, case for us to keep in mind, but I can't tell you the number of patients that have been sent to me, exactly, runners. The orthopedists, actually, some of them were treated for anterior compartment syndrome, did not get better, and they say maybe it's venous, and clearly I knew nothing about this diagnosis, but they should be aware of this too, as cause of the pain. And I'd be curious, it seems it's mostly in the lower leg, in the tibia.
Mm-hmm.
Very, very interesting, really. I think so.
Two comments, Tom O'Donnell here. One, it's surprising that we haven't found more of these, because someone has leg pains and most orthopedic sports medicines send them right for an MRI. So that's curious. Secondly, the more common presentation of people who really have trouble with Klippel-Trenaunay syndrome is when they have interosseous involvement. It's a cause of severe pain. And indeed, Casey Martin, the pretty good golfer that lives out in Mark Mises, that's his major problem now, is incredible pain in his leg from his interosseous malformations, venous malformations.
And Tom, we see a fair number of interosseous venous malformations, and just because sometimes there's a concern of fracture, we've usually treated those with cyanoacrylate, which is Trufil. Is that something you considered, Tom?
No, I haven't thought about treating it. It seems like would be a potential way to do that.
Can you see it with ultrasound? The defect in the bone?
I don't think so. I can't.
No, I can. Mark, you can. You can see the defect on the bone easily, yes.
It seems like it's a simple thing to stick a needle in it under ultrasound and just inject some Trufil.
I did include in this, I did throw in that x-ray and didn't comment on it, but you can see right there where the vein I showed you actually exits. This was the ground zero.
Very, very interesting.
Anyway, I thought this, if any group in the world would appreciate thinking about this, at least to be you guys. So thank you very much.
And Tom, thank you. You've educated all of us, and you've educated all the attendees as well. This comes to the end of the first day. We really want to thank all the panelists and the faculty and everybody for a fantastic discussion. For the great majority of the 3 hours, we had more than 200 people on listening and commenting in the chat session and the Q&A as well. We'll get to some of the Q&As for some of you that we didn't get your questions answered. Be back again tomorrow, 11 a.m. New York time, same hours as today. We have other things. You can look on the website to see what we're talking about. But once again, very nice and interactive. We want to thank all of you for hanging in there. being with us, and suggestions at any point. This is the first go around for all of us, the industry, for Radcliffe, and for ourselves. Pretty happy with how it went, but we can always improve. So let us all know what you liked and what you didn't like. So again, thank you, everybody. Thank you, and hopefully we'll see you all tomorrow.